Yes, now on behalf of the Academy of Orthopedic Manual Physical Therapists, the General Secretary, Dr. Darshana Jani, she'll give the welcome address, give the participants an overview of the importance of ligament injuries, and also guide them in how they can utilize this webinar session the best through the interactions, right? Over to Dr. Darshana Jani. Yes,
Yeah.
ma'am.
Good evening, sir, and good evening to all the participants. A warm welcome on behalf of AOMPT. I think it's a wonderful decision to start the instability course, which is beginning tomorrow with the interactive session today. And I think all the participants are lucky enough who have registered today, as we have really been understanding how to evaluate articular, myofascial, and neural dysfunctions. But most of the times, I think for me, of course, I find it very tricky to assess if there's a ligament instability and to really decide upon the right approach of treatment to achieve the functional goals of recovery. So understanding the instabilities is, of course, a very, very important aspect of our assessment. And I think nothing better than attending the course, which is going to start from tomorrow. So from a clinical perspective, I would say that this interactive session itself is going to be very useful, as we might understand all the basics of how to evaluate, how to correlate the clinical presentations with the evaluation what we get, and of course, the right treatment planning. And questions from all the participants would definitely enhance our thinking skills towards evaluation and treatment of instabilities. A very, very important aspect from clinical perspective. Yeah. So I think, thank you, sir. And this is a great start with the interactive session today.
Yes, definitely. Madam was emphasizing that functional, okay? The topic is structure, ligament, but the subject do not come with the ligament, they can come with a diagnosis that I have a ligament injury, I have a ligament strain, I have a ligament sprain. They can tell any of these terms. Sports persons definitely will come and tell that I have a torn ligament. Okay, they're very proud to tell that.
Yeah.
And they will also tell that I have a torn ligament for past 3 years. Okay, and I have played that game also. Okay, competitions also I went for Asian level. So this is the typical story. Another sedentary people, the moment they know that it is a ligament tear, they get panic, and patients do come with a lot of fear and what is called as an apprehension that it's a serious injury, something like a dislocation. Okay, this is what comes to their mind the moment immediately a physician tells ligament injury. Whenever these people come with kind of a structural diagnosis, the physician always talks about structures, because for them the anatomy, pathoanatomy, surgery also is rectifying the anatomy for a surgeon. But for a physical therapist, what is most important more than the structure is the patient. The full patient is important, because when both the knees are there, only one knee, why the ligament tear is coming? When both the ankles are there, why only ankle sprain is coming only one side? And the next one, being a child or being an elderly, the patient's physiological status, how it will influence the therapeutic response. Because everybody will not have a same effect of an exercise, or even a thermal or electrical modality will vary individuals and individuals. And of course, a person who is having injury, repeated injuries, versus person who is having injury first time. So that cannot be treated as similar. Gone are those days when we go with acronyms, where soft tissue injuries were treated with whichever rice, price, pickle, lemon, whichever. Okay. What's important here is to see that kind of what is called as a prescription-based treatment, like first you give this, next you give that, next you give this. Okay. And it's not going to help the people, because a lot of differences exist in the strength of ligaments also between people. And of course, it's to do with nutrition and lifestyle, okay, predominantly. Even the habits of the individual, activity, physical activity level of the individual, So everything makes a bigger picture. We have been having courses in AOMPT, and the three people who are sharing my screen here is the core committee, and they have been with the AOMPT right from the launch of the online courses ever since the COVID-19 launched the lockdown, okay, and AOMPT launched the online courses, okay. So in full-fledged cooperation and teamwork from the three people who are sitting beside me here, Dr. Ritu, Dr. Sharwani, and Dr. Darshana. Okay? So they are my co-hosts for today. They will also be adding on with their points, and they can add additional queries to any of my explanations for the participants. I really appreciate the enthusiasm of the participants. One, because this is a very, very important topic. This is a common thing which we see in our clinical practice. And everybody comes with maybe a OA osteoarthritis of the knee, but you find that it is actually a lateral collateral ligament injury or a medial meniscus injury. Okay, so you will find that the physios who are actually treating would have known that it's not just people who can be combined with a disorder. Okay, and even for example, lateral ankle sprains, another one. Another is even the foot pain. If people are having foot pain, they are likely to have that intertarsal ligaments injuries. So sometimes that might aggravate with different footwear. Okay, so unless we evaluate the complex interaction of this biological, psychological, and social, and do not forget our biomechanical foundation, okay, as we are trying to do our best for the patients. Okay, I really hope that, definitely not just hope, I know that all of you will transform in your thinking process, in your clinical decision making. And the participants, of course, the three of them are also enrolled for the tomorrow's course, the major course of certified ligament injury and instability specialist courses. In the past 3 months, we have been having specialist courses of the AOMPT, which covers right from basic till the advanced and even futuristic. Okay, what could be the further developments of knowledge and techniques? Okay, so that the participants can evolve their own techniques to match the patient. Okay, so that is important thing. It's not like whatever we have, that alone we keep mixing and giving. Okay, so we should think in terms of what is needed by the patient. A ligament injury subject who's having difficulty with walking is different from a ligament injury subject who's telling just pain on standing. Okay, so the same lateral ankle sprain it can, or it could be even a clicks in the hip joint. Okay, so that can come with squatting for some people. It comes with sit to stand for some people. It comes with the Padmasana, the yoga position, the sitting position, okay, for some people. So remember that it can come with different history. Okay, so that is why we need not only history, the tissues that are in dysfunction also. If you treat only the ligament, what happens afterwards is the healing will be 80-90% maximum, and the subject might discontinue the therapy and go. If you are not concentrating on the muscle imbalance, not concentrating on the functional aspects, how the person is used to be in functional activities, if that is not treated, then what happens is the subject comes back eventually in maximum 6 months. They'll again come back with another injury, same ligament. Okay, so remember that this is something which you don't want the patient to come with the same problem again and again. Okay, patient can come with another problem. They are definitely welcome to come and visit us because they were satisfied with the earlier treatment. And another one which now you have to be very careful is the post-COVID scenario, where the people are used to be a little sedentary lifestyle. Okay, the change in routine, huge psychological demand and stress if they are not able to adapt to that demand. Okay, so individuals do have their own concerns with financial aspects also. And of course, when you see for people who are having ligament injuries in multiple joints, okay, the moment you think that they might have even spinal instabilities, but spinal is not part of the tomorrow's course. We are talking about the cervical in the cervical specialist course, which completed in July. And we had the masterclass on the lumbar instability in the lumbar specialist course, okay, the lumbar spine specialist course, just few days before. till the 20th of September it was. So it's important to see that peripheral joints, multiple joints, if somebody is having a problem, ligament sprains and strains on and off, earlier shoulder clicks, now ankle is clicking, okay? So then you should think of more systemic, okay? And see for what is the one which is causing ligaments to be weaker at multiple areas, okay? So even a bilateral problem, if this side ankle, definitely will indicate more systemic problems like connective tissue disorders. By connective tissue disorders, I mean like the ones which are increasing the inflammatory response in the blood. It may be ankylosing spondylitis like HLA-B27. It's present in most of us, but it does not manifest because our immune system knows which is our tissue, which is external tissue. Okay, but there will be a time when that compromise happens. Our body attacks, our immune system attacks our own body. That is called as the autoimmune manifestations. That leads to the change in the collagen fibers, the immune system attacking our own ligaments, capsule, everything. So that is how this disorders come in the picture. Okay, right from rheumatoid arthritis also. So don't expect that people will have a rheumatoid arthritis, then they have a ligament sprain. Some people might, early stage of rheumatoid arthritis will present only with bilateral ligament sprain. Okay. So you should be very clear that if they have not gone into a physician and investigations, and they have come with a ligament sprain which is bilateral, both the sides, you should definitely think. Okay. And if that ligament sprain is involving early morning stiffness, then the risk is more, okay, to think of polyarthritis, okay, the early stage of polyarthritis like that. So it's very, very important to recognize these clinical presentations. One thing which I'm very happy today is the questions which I've already started, okay. So I announced that please post your questions, and everyone started posting questions. It is like, I cannot have a better example than it is like what is called as, you know, you are diving into the sea or in the water, okay, deep sea diving. You don't have an oxygen supplement, okay, you don't have any kind of an external breathing supplement, and then you come to the surface, okay. When will you come to the surface? When you are actually not able to breathe, okay, inside the water. So when you come to the surface, how will you take the breath? Okay, that same like that, seeing the questions, okay, gives that happiness. Okay, so I cannot describe much better than this experience. Of course, the three of them who are sitting here knows the value, how much I give to the questions. Okay, so all participants, remember that when you're asking your questions, putting it on the chat, please take a screenshot immediately. And these screenshots you have to submit after the webinar so that you can get that free e-certificate, as I had circulated the sample with a beautiful certificate. And right. So Dr. Sharwani will begin the proceedings. She'll read some of the questions at the beginning, and later I'll switch on to Dr. Darshana and Dr. Ritu. So when Sharwani ma'am is reading the questions, you can have contributions from Dr. Darshana and Ritu. Okay, anytime you can add on with your points, right? Yes, Sharwani, go ahead.
Yes, sir. Sir, our first question is by Dr. Vijay Ramkrishna. Is the taping will permanent or temporary treatment for ligament injury? Please elaborate knee ligaments, ACL or PCL or MCL injury special tests.
Okay. So first and foremost, taping is an adjunct. Okay, it is not called as a treatment, and you are just reinforcing the ligament with another external material which is stuck to the body. The ligament is not able to give the feedback. It is getting either tissue damage, so pain is there, and the remaining fibers are getting lengthened and pain is there, more pain. Okay, so you don't want the ligament to get stretched. So what we can do is on the skin, we apply the tape. One is, so it will prevent the ligament from getting more stretched. At the same time, the skin where the tape is applied will give a stretching sensation immediately when we are doing that loading activities. of the ligament. Okay, whichever our activities load that ligament. Load means it will be lengthening that ligament. I'll get an input from my skin. So the inputs which are not available from the ligament, because the ligament is injured, will be now be given by the skin extroceptive sensation. Okay, the skin stretch sensation. So that will make me to stop the movement. Okay, so if I am applying the tape here, that means when I am bending, it will stretch so that I will stop the movement. Okay, so it gives a substitute for proprioception. Why am I using the tape? Whether it will add on to the healing, not necessarily, but it can prevent aggravation of injury. Okay, so more and more ignorance and more sudden activity. If I have to go for my work, I have a ligament injury, I have to walk and go, or I have to use my two-wheeler. Definitely there is a risk that when I keep my foot, I can get a ligament twisted in my ankle. Okay, so I can put the tape in the morning and then go for my job, then come back evening without aggravating the injury. Okay, so tape is a prophylactic one. Even in the field, on-field management and sports injuries also, tape is just given to continue the game. Okay, for an elite player, they have to continue the game, so you apply the tape. When they come back after the game, we have to remove the tape and give the actual treatments for the ligaments. So taping alone will not be a treatment. At the same time, no treatment will be permanent. Remember one thing, every treatment is always as per the dysfunction. If the dysfunction is rectified, if the patient is got better, and always any kind of a passive treatment, like be it electrical modalities, be it taping, or even the manual techniques which are passive, should be discontinued as early as possible. Always we should switch to the active method, and exercises and motor control and functional training that could continue lifelong, but not the what is called as, even the exercises also, local exercises you should not continue lifelong. Okay, so you should always think of functional activities and then proprioceptive agility drills, balance training, all that. So that can continue lifelong. There's no harm in continuing that. So definitely its effect will be temporary only. Even when you apply the tape also, two types of taping. One is the rigid tape, which is not stretchable. Another is the elastic one, which is the kinesio tape. Both the tapes, if you see, they cannot last beyond a particular duration. You're putting the tape itself, it will go off in 3 hours. Okay, if it is the main effect of kinesio tape itself reduces in 6 hours, rigid tape reduces in 3 hours. Now the patient actually continues with functional activities. So ensure that the tape's efficacy only lasts for this much time. Okay, it is also different if the patient is obese and then you are using it on a lower limb, it might go more shorter duration. Okay, there will not be any effect of the tape in terms of mechanically protecting the ligament, but the skin stretch, that stimulus will be there. So a patient will know that I have to take care of my posture, or it is the movements. Okay, in both the ways it can give feedback. When it comes to special tests, don't run behind special tests. Why I'm telling is because in everybody you cannot do the special tests. Some of the stage of the ligament injury, you do the special tests are all provocative tests. They all actually load the ligament and they have the tendency to injure the ligament more. Okay, so these special tests are devised by orthopedic surgeons as a confirmation, preoperative confirmation. Okay, same way how they use the MRI, the magnetic resonance imaging, or it is the diagnostic ultrasounds. Okay, so remember that special tests are not necessarily to be performed at all. They are named as special. So you should remember that it is not for general use. Okay, it is only for people who do not have any reproduction of symptoms by any other tests. Okay, where you are not getting the picture, the pathomechanical interpretation. I am not able to get that injury is there. Okay, of a ligament. The subject is not getting provoked with running, jumping, any activity, functional, nothing. But I want to clear whether anterior cruciate ligament is proper or not. Then only I will do the Latchman's test or anterior drawers test. The same applies for a PCL where posterior drawers or the posterior sag sign or the pivot shift test. Whereas For the medial collateral ligament, it is the valgus test. And the lateral collateral ligament, it's the varus test. If it is the ligaments in the knee, okay. And the medial meniscus and lateral meniscus both are tested with the McMurray test for the stretch of the menisci, and Apley's compression and distraction test again for compression of the meniscus, stretch for the collateral ligaments. Okay. So these tests are devised only by orthopedic surgeons in their own names, and their only purpose is preoperative. So as physical therapist, I will not advise you doing the special test. I would rather prefer a functional palpation is better. Okay. And make sure that your knowledge of which activities will load which ligaments. Okay. That is important. A player is playing means what is the way he twisted and fell down. And then laterally you are palpating, right? Okay. So you have to have that mind that what laterally, what are all the structures there? Okay. Which are all the ligaments there? Okay. And then you see for, you can load to an extent where minimally you can see for with the symptom, okay, with the patient's response, then you can load. That is called as the functional palpation. Maybe I will give a distraction to the joint and see rather than doing abduction, adduction. Okay. So you might reduce the load. Okay. So, and then you will combine with the palpation. Okay. So during palpation, you will give that load. And then you can do that. But I will not advise doing the valgus varus test itself. Okay. When on the field or anything. Okay. So remember that also, if the joint position itself is abnormal, okay, subject comes with a joint position that is abnormal, means you know that the lateral collateral ligament of the metacarpophalangeal joint might be torn. Okay. So alignment is important. Or I find that the tibia is more anterior. Okay. This is femur. This is tibia. It's more anterior. I can feel the tibial tubercle. I can feel that anterior margin of the tibia. I know that there's an insufficiency of ACL, anterior cruciate ligament, because that is the one which stops the anterior translation. Okay. So, right at rest also, I can palpate the bony surfaces and I can find the alignment. And the another one is with the palpation, attachment to attachment, because most of the ligaments are subcutaneous, superficial, barring the ACL, PCL. Okay. Otherwise, all are palpable easily. So when you are palpating, then minimally give a loading, confirm. And of course, the next thing is our treatment-based relief. Okay. Our plan should go to how to relieve the symptom. Okay. How to make them functional. Tissues will take its own time to heal. It might range from 3 weeks to 6 weeks. Okay. But what's important for us is to ensure that during that period, again, abnormal load on the ligament should not come. And during that period, the proprioceptive mechanism not there, at least the exteroceptive input should be there, or the muscle reconditioning should be done. So that if the knee muscles are insufficient to contract, if the knee ligament injuries, give the hip and the ankle. Okay. So don't wait for particular muscles to recover and then delay the exercises. Okay. There are various methods by which we can give exercises to one joint without influencing the another. Okay. Even in a closed kinematic chain exercises. Okay. We are aware in ACL rehab that wall lean squatting. Okay. So this wall lean squatting, this has a particular mechanics. So it will not load the ACL ligament. At the same time, strengthens the quadriceps proximally, and of course, not distally. Okay. If quadriceps is contracting distally, means anterior translation of tibia will happen. Okay. So in a closed kinematic chain, always the origin only moves. Okay. The muscles. So squatting, and the COG is kept posterior. So hamstring also comes in the picture there, co-contraction. So a lot of things are to do with our understanding of the mechanics. If we can't understand the mechanics, we should get ourselves trained adequately. We should interact with more people to find out. And we should also explore different positions where the subject feels relief. Okay. Or at least not aggravating of the symptom. Okay. If a subject tells that squatting is problem, I will try to assess whether the squatting could be done with one leg forward, another leg behind, and then squatting. Okay. So I will modify with abducted squatting, adducted squatting. Okay. I will recheck how it influences. Okay. Or that same squatting with the trunk rotations and then squatting trunk ipsilateral or contralateral rotation, and then the squatting. Okay. So I can even wall lean squatting is one thing. Another is a forward support, forward lean squatting. Okay. So whatever I do, the problem is squatting. So my aim to treat should be the squatting. Okay. Ligaments, I cannot go inside the body to make sure that it is healed. Okay. So if we are protecting it and we are going through a staged rehab, definitely the motor control is better. The subject can have functionally independent and normal activity, even with the 3rd-degree tear of a ligament. Okay. With all the neuromuscular control intact, and the subject can participate in even advanced sports without even a brace. Okay. So remember that body has that ability. So trust on the muscles. Definitely. It's not possible for people who have muscle weakness and insufficiencies like neuromuscular disorders. Okay. So for them, it is very tough. If there is a peripheral nerve injury and then muscles are weak, then also it's tough. So those kind of situations are exceptions are there. Otherwise, and connective tissue disorders, because the ligament's property is altered, so it's very tough. Okay, you cannot get the recovery. But in mechanical problems, typical sports injuries, sedentary individual, or be it the sports, the influence or interference comes from psychological. Okay, some players cannot just wait for the graded progression. They want to be in a hurry. They want to get into the mainstream sports immediately. So in that bargain, maybe they might re-injure. Okay. So otherwise, don't go behind the special tests. Okay. Yes, Dr. Sharwin.
Yes, sir. Sir, our next question is by Dr. Abhishek Singh. Is ACL surgery the right option for every person?
Anything is not the right option for every person. Okay. It is like you can't tell that everyone will like a soft drink, everyone will like fruit juice. Okay. So it is to be individualized. And first and foremost, the indication for surgery when you are seeing for ACL rehab has its own criteria. Okay, that hemarthrosis. Okay, after the ACL injury, that hemarthrosis comes within 24 hours. Okay, because there are blood vessels inside the ACL, and if they are torn, then only the hemarthrosis happens. Okay, the accumulation of blood in the joint. So if not, surgery is not indicated. Okay, and the next one, popping sound. Okay, loud popping sound was heard. That is complete tear of the ACL. Okay, so that also indicates that locking episodes of the knee. That is third. So that means you have ACL with MCL and medial meniscus. Then only it will go for locking. Remember, any locking episodes in the knee will come after meniscal injuries. Okay, if it is only collateral ligament, only ACL, locking episodes will not come. Because of meniscal injuries, only locking comes. Okay, so it's a multi-directional instability. That is the term called as, because ACL is for anteroposterior, MCL is for mediolateral, and menisci are for the transverse stability, rotation. Okay, so multi-directional instability. So that situation, if it is there also, surgery. Or a ligament injury together with a nerve injury, or what is called as a fracture. Okay, avulsion, a ligament avulsion from the attachment. Okay, so those kind of scenarios, the surgery is immediately indicated. Okay, and ACL, why we are telling that surgery is needed is because the major role of the ligament itself, 3-dimensionally, it stabilizes the knee. Okay, so it might give valgus force also, it will stabilize. Okay, it might stabilize anteroposterior also, it will stabilize against internal rotation of tibia also. Okay, so adduction of the tibia, internal rotation of tibia, and of course the anterior translation of tibia. All three are assisted by the ACL. Okay, so if that is compromised, the knee actually becomes very risky, that it can go for osteoarthritis in the future. Okay, so because of the inappropriate contact areas. Okay, so if there is instability, means cartilage damage, and later it may complicate. So that is also another reason why if there is even a partial tear, repairing the ligament versus reconstruction of the ligament. Okay, there are two things. Both are surgery only. Or even sometimes the surgery of arthroscopic debridement, it is called as. Okay, so there might be a torn piece of a ligament, which is a loose body. So the loose body can be removed out of the knee joint. Okay, and the area which is anywhere it is injury is there. There also the surgeon can do the minimal repairs. Okay, so these are minimally invasive surgeries like arthroscopy. Okay, so it's not like every surgery is surgery. Okay, so if I'm doing an abdominal surgery means don't generalize the abdominal surgeries. Laparoscopy versus laparotomy, it's totally different. Scopy is definitely better. And in that also, appendicectomy is nothing. But if the same is hysterectomy, you should think twice. Okay? So always remember. And what is important here is not to miss the fact that the individual indication only will go for surgery. The ligament injuries in an elderly will not go for surgery. Okay? That fast. Ligament injury in children also it is not needed. Okay? Because they are in the growing phase. You cannot just reconstruct the ligament and then expect that the artificial ligament will adapt to the growing spurt, okay, growth spurt. We always tell 15 years around that, okay, 12 to 18 years, the growth spurt. So that time, if artificial ligament is there, means will it adapt to the lengthening according to the growth of the bones? It will not. So that's why it's a huge problem that they will not do even fracture implant also. If you are keeping implant on the bone also, they think twice. Lower upper limb they'll keep, but lower limb they'll not. So always remember, surgery is dependent upon lot of criteria and tissue also. Okay, so don't think that surgery is the cure. Of course, surgeons are under pressure nowadays that to perform at least 5 surgeries every month. Okay, the corporate hospitals are giving too much of pressure. That is the commercial side of the healthcare. Okay, so where they are forced to do surgeries. So even grade 1 tear also they'll be doing reconstruction of ACL. Okay, and if the hospital is attached to a medical college, where in that medical college they have MS Ortho. Okay, students are there for MS Ortho, so they need some experience with doing the reconstruction surgery. They cannot wait for the subject to come with 3rd degree, then after that do the surgery. So what they will do? 1st degree only do the surgery, PG will be doing the surgery. Okay, so that might happen. This the same thing happens with cardiology also. People have cardiology students, and in the college there's a teaching hospital, and the patient comes with only minimal block or transient block. Okay, they will tell that angioplasty has to be done. Okay, because the students have to get exposure for the angioplasty. Somebody they have to do on a daily directly. And of course, income for the surgeon also and hospital targets. Okay, so there are things in an inpatient setting. It's totally different. It might conflict with your decisions also. Okay, so ensure that you are able to strike a balance, although it is really very tough. Okay, we should not touch that aspect. Okay, why surgery? Because the question is directed by Abhishek. It's clearly understandable that he is an orthopedic surgeon, is operating all the patients who are having ACL tears. Okay, so that is why he's asking, is surgery the treatment for everyone? Okay, so and they are sent to physiotherapy like preparing for surgery. After the surgery, they will tell, make them normal, make them normal. Somehow you have to make them normal because improvement after surgery, surgeon is more responsible. Okay, so that is the way they take it. So sometimes it's unfortunate. That is the reason why all our courses we are emphasizing on patient-centered model, not the technique-centered. If I am a surgeon, if I am thinking that I am also a human being, patient is a human being, I am patient-centered, I will not do the surgery. Okay, if technique-centered, my surgery procedure is important. The procedure gives me money. The procedure will give me an exposure for my postgraduate students. Okay, so everything is centered, technique centered. Then only I will be becoming commercial. Okay, so it comes to even resource persons also. Okay, so remember that you should know when not to do a surgery. Okay, and if the patient is motivated that I don't need a surgery, please don't change their mind, create the fear, and refer for a surgery or refer for an MRI just because you are getting a cut, okay, or a commission. Okay, So that's also other side of the story. Yes. Next question.
Yes, sir. Sir, our next question is by Dr. Pranali More. What is the rehab strategy for ACL injury?
Every ligament, the rehab strategies, there are a lot of literature that is available. Okay. As I was telling that the functions of the ACL, okay, anterior translation, or the abduction of the tibia, or the internal rotation of the tibia. In this three itself, a patient who has an ACL injury can come with either of the three directions problem or all the three. Okay. Isolated ACL injury with combined ACL injury, other MCL or medial meniscus injuries. Okay. So there are a lot of pictures which you have to take care and then plan the rehab. Finally, what you are actually going to do. In my target, what AOMPT, we don't have a special protocol for that. Of course, the core committee can sit and write down and plan it as a protocol. I always teach more clinical, more direct, more realistic. Okay. So I would try to see that the patient is having the indication for surgery. I know I have already mentioned the previous discussion. So if the patient is not having that, and then I am sure that there is no avulsion fracture, there is nothing that is serious with the ligament, then I know that it's grade 2 or 1. Okay. So between the grade 2 and 1, now the question comes to a patient who is running for a long time. After that, he is getting pain in the knee. Okay. Mostly it should be a grade 1. Okay. Because grade 2 will have symptoms immediately on weight bearing or in few steps. Okay. So it can come much earlier than an overuse. Okay. So the ligament symptom is coming at rest. That is in the supine position itself, the subject is bending the knee and straightening the knee and he is getting symptoms. That is open kinematic chain. That is first category, the high precaution category. The other ones who are not having any symptoms in the supine line, but in weight bearing. So the one who is having in standing versus the one who is having in regular walking itself, that is the moderate category. Okay, because standing is minimal load. Normal walking is daily activity. So that is also minimal load. Okay, moderate category. There also precaution is needed. But the other one who tells stair climbing, squatting, or running, definitely I know that it is the end range activity. There is much more loading in that. Okay. And the patient will also tell that stair climbing after 20 steps, 30 steps, then I am starting to have pain then. Okay. Or I am not able to put that knee and then climb the stairs. Okay. So then definitely I know that it is a overuse related. Okay. So that is the picture where I can do a near full examination. Still, I will not do the special test there. Okay. So in everybody, so my plan who is in supine should be ensured that first immediate, what is my plan is the supine, whatever that symptom is there should go off. Okay. He should be relieved. That is the primary thing for me. The other one who is standing or other one who is walking, that standing or walking symptom should reduce substantially, at least 50%. Okay. I cannot go full. But the other one who is overuse, I can definitely ensure that that functional activity will be normal without any symptoms. Okay. At least in 3 weeks. Okay. So it depends on the presentation then. Okay. So the person who is having in rest, he's having a knee movements and then having pain in the ligaments and this is supine position in open kinematic chain. Might take 3 months to recover. Okay, full, maybe an extended period because you are expecting a damage which would have changed the alignment of the joint, and that changed alignment of the joint is present even during rest. Okay, so that is the instability there, static instability. Okay, so at the same time when you are seeing for standing or walking, you can think of closed kinematic chain. So closed kinematic chain, there is a ligament damage, but associated some kind of capsule damage, synovial membrane damage. So that is getting compressed on standing. Okay, there is an impingement. Okay, so that is standing or weight bearing. Okay, that is there immediately. Okay, so it's not just the ligament injury, maybe another associated injury there. When it is coming as overuse, I know that it is the muscle imbalance, the motor control or the neuromuscular control, or the proprioception deficit because of a fatigue. Okay, so then only the ligaments are getting loaded. So it's very easy to rehab that patient by active rehabilitation programs. Okay. So I will not bother about whether it is grade 1 or 2 or 3. I will only be bothered about whether it is in open kinematic chain, in closed kinematic chain versus overuse. Okay. So in this, what happens is, I think now our core committee members would have got a clue what we are going to see in the course. Okay. So what's important here is, here, even if the structural instability or functional instability, there are two types of terms. Okay. Structural means the ones which is like supine lying open kinematic chain where it is problematic because alignment is problem. Structural alignment is problem. So moving anytime, any movement, any position, it will be problem. Okay. So functional one is in the functional, static and dynamic. Okay. Or overuse. Overuse will be extended one, the last option, where non-irritable presentations. Okay, so you have people who are walking for kilometers. After that, they have the ankle twist. Okay, so they have a long journey. After that, at the end of the day, they'll have an ankle twist. That is called as a functional instability, which is overuse related. Okay, at the same time, a person who is having with walking, regular walking, but after 10 to 20 steps, immediately it comes. Okay. So initial standing does not come. Initial step itself, it does not come. Okay. So then I know that there is some kind of an imbalance that comes, interaction of foot, knee, and hip. Okay. The kinetic chain interaction that comes in walking than in standing. Okay. So in standing, it is actually a structural damage, but static functional loading. Okay. So even sitting also for patella, static functional loading. So static functional, static, what is called a dynamic functional, okay, and overuse, like that categories will come. And here it is static and structural. Okay. Here also at rest also the subject can have, and dynamic structural is there. What is that? In supine itself, movement is causing the pain. Okay. So that is dynamic and structural. Okay, positional. So think of these categories because these categories are not available in any literature. Okay, this is actually a problem-oriented approach. Okay, patients having problem at rest without movements. Another is having problems in the resting position during movement only, or mild pain at rest. During movement, it becomes more. Okay, and then the third one comes to functional position and static. Okay, like standing. And functional position and dynamic, which is like moving or squatting or stair climbing, okay, walking like that. Another one is the last one, which is overuse, which will be the sports category also. Okay, people who are actually playing the elite level competitive sports, they get that injuries. So this will fit into all kinds of categories. Okay, don't go by the structural damage because patient may have a grade 1 tear, but the associated tissues are not that much adapting. Okay, homeostasis is not proper. I can have a grade 1 injury with too much of symptoms, too much of difficulty with functional activities. Okay, so you are not treating the structure, you are treating the function. Okay, and the next one is grade 2, grade 3 also. Patients may not have pain. Many people don't have any functional deficits that much. Okay, they're able to continue with their daily activities. So we see both the spectrum. So gone are those days where you think about the protocol of rehab, grade 1, 2, 3 injuries and all those things. Okay. So try to get it to the functional symptoms, what the subject will tell. If you are having a ligament injury, what you are bothered about? I'm not able to squat. Okay. So that is my problem. Okay. Or I am squatting and I am getting up, my knee is getting locked. Okay. So this is a functional dynamic. It's not overuse. Okay. So this kind of things, a sustained posture and then transition, that also will come under dynamic only. It will not come under overuse. So you can have that, distinct subgrouping. Okay, functional, so as to structural. Okay, both this. So remember that structural damage never correlates with the functional deficits. Okay, so don't go behind structures. It is like hide and seek. You will never find the treasure. Okay. Of course, if you are going behind the functional activities, patient will feel that finding such a therapist is my treasure. Okay. So that is important. It's not you finding the treasure that is important. The patient should feel that you are the treasure. Okay. That is important. Right. Yes, we continue further questions by Dr. Darshana. Yes.
Yes, sir. So 1 minute.
Dr. Sharvani is attending on laptop, so she can easily read the questions parallelly.
Okay. So 1 minute. Huh? So I don't know whether I've missed any questions
In
before
the Zoom,
Dr. Manjula's question. Yeah. Are there any questions
you would be
before?
only 3 questions. Okay. PCL.
Yeah, I think only 3 questions I missed. So first two, Dr. Sharvani is read. I don't have the third
We
question.
have why Divakar Kumar. ACL injury is more
Okay.
common.
Yes. Okay, fine. That question I have then. So Dr. Divakar has asked why ACL injury is more common than PCL or other knee ligament injury.
It is not necessarily like that. As I was telling, that multidimensional role. Okay. So that ACL is challenged with any of these forces. Okay. So if not one, it is another. Another is closed kinematic chain, functional activities, knee stability. And if you see for any kind of a ligament, why it gets injured. Okay. So it means the fibers, how the orientation are. If the fibers are linear, okay, linear means all fibers are like this. So from proximal to distal, they're all vertical. Okay. So if that is the case, injuries chances are very minimal. Why? Because to tear that, even if you lengthen, it is only along the fibers length. Okay. So it's very difficult to tear it. But if the fibers are twisted, okay, if it is twisted like this, it might look like it is strong. Okay, because all the fibers are together in the area where it's twisted. Okay, so but the whole function of the ligament is twisting and untwisting. Okay, so that is the function of ACL and PCL, both of them. Why they are called cruciate ligaments is not just because they are crossing each other. It is also because the fiber origin to the insertion itself, there is a twist. Okay, so anteromedial fibers and posterolateral fibers. Okay, like that. So these fiber sets are totally different. And because of the twisted nature, one thing is their mechanical property also. If you are again and again not using the ligament adequate optimal loading, the ligament goes for weakness. Okay, very easily, because a twisted ligament will go for easy weakness. Okay, so advantage is there, disadvantage is also there. And next one is, of course, the activities will produce when you are talking about body weight, when it is there in closed kinematic chain, where the femur can move with the body and the foot may be stuck in the floor or in the ground, okay, when during the game. So because of footwear and spikes, okay, there is a lot of grip of the foot. So foot slipping is very rare in sports. But if you see thigh, body, knee will be one position and the body will move another directions. Okay, these kind of things are. So in that load, what happens? The femoral directions also movements. ACL is more. Another is PCL has reinforcing support. You can see the knee joint anterior capsule versus posterior capsule. Anterior capsule is loose to allow the patella. Okay, so you don't have an anterior stability other than the ACL. But if you see other than the quadriceps tendon, of course. Okay, and but if you see for in that, unfortunately, both are there, but the quadriceps tendon is antagonistic to the ACL. Okay, so if the tendon contracts, quadriceps contracts means anterior translation. So it will create further loading on the ACL anteriorly. Posteriorly, posterior capsule is there, and PCL has a lot of PCL is like a dawn. Okay, so you have medially ligaments and laterally also ligaments that is supporting the PCL. Medially, the ligaments of Humphrey and Risberg. Laterally, the arcuate popliteal ligament and oblique popliteal ligaments, the supports are there. So PCL is very, very, what to say, secure. Okay, that what is called as the bouncers are there. Okay, with the PCL. So it cannot go for injuries. Okay, it's a celebrity heroine. Okay, PCL is. Hero only goes for the injury, ACL, because that is the one which is maximally fighting and then doing all the action throughout the movie. Okay, so you see Shah Rukh Khan always getting injuries. Never Kajol will get injury. Only climax she will get injury. Okay, so remember PCL injury will come only if it's a very unavoidable, unexpected circumstances like that injuries, okay, like dashboard injuries, where hitting the tibia, okay, then it can injure, okay, trauma, direct road traffic accidents. But functional activities will definitely injure the ACL more. Another which you see for the fiber strength between ACL and PCL also, PCL is stronger, okay. So always that also determines, okay, when we see the proportion of the what is called the percentage strength, okay, ACL is stronger or PCL is stronger, right? That means PCL is much more stronger, okay.
Yeah.
And so remember, and one more thing, don't go by the statistics, okay, which is more, which is not more, okay, why it is more, okay, what it is going to do with your rehab, that alone you see, okay. Patient is come with a symptom in the knee. Your goal is to see whether PCL is also injured, okay, or ACL alone is injured. That is what is your priority. Or you have to find whether primary PCL, secondary ACL, primary ACL, then secondary PCL. Okay. So both the directions, anteroposterior instability of the knee. Okay. So you need to know which ligament is the first injured, which is next. Okay. So your evaluation should go like that. You are not thinking about what is more common, so why it is more common. You are not going to change the past. You are not going to change the mechanism of injury. Okay. So what you have to see is functionally plan. Okay. And see that even if the patient has individual injuries or multiple injuries, your goal should be to get the patient back into function, either by applying a brace and then you give a functional training, or you give a tape and then give the functional training. Okay. Or you minimally use that affected joint, train the hip and the ankle during the functional training, but do not delay the functional training. Okay, so that is what. If the patient is having pain on functional training, trying to see that even with mobilization with movements, okay, people who have lateral ankle sprains, you have problem with putting the weight and lunging forward or squatting. So the stair climbing, patients can have problems. So that means you can give the mobilization with movement to the talus or to the lateral malleolus. Okay, we are all aware of this. So remember that even mobilization with movement could be used together during we do the functional rehab. Okay, so it's you cannot delay the functional rehab thinking that joint will heal later. I will treat the muscle. Okay, if you treat the muscle, then only the ligament healing is faster. One important thing with functional is the more you delay a functional activity, more the disability goes into the brain. Okay, I am not able to do squatting, I am not able to do stair climbing. Okay, central sensitization. So because of which activation of the muscles will be further delayed. So you are complicating the recovery. So always make sure that functional should be there as much as possible. If the patient is complaining supine lying, resting symptoms, I am not telling functional. But even then also, there also, I will incorporate some kind of a weight bearing. Okay. Either with mimicking the functional activities. Okay? So that is how the treatment goal should be. Okay? So that the brain has that ability to feel that yes, I am doing something similar to my functional activity. So all the muscle recruitment will become much better and faster recovery will come by descending inhibitions. Okay. Even if one side is seriously affected, one ligament injured one side, give the exercises to the other side. Okay. There is always a crossover effect. Normal side also quadriceps and hamstrings keep on strengthening even in supine lying. You will see the difference that subject when they come standing and stair climbing. Other leg is strong also, it will reduce the load on this leg. You know, mechanically itself it reduces the load. But centrally also, you train the other leg also, this recovery here it will be faster. Okay. So do not think about all this keeping ice and then bandaging and all. Okay. Unnecessary. If the only the indication structural damage is there, then you can do that. Okay. Otherwise, functional should be the target.
Yes.
Yes.
Yeah. Then we have a question by Dr. Roshni. She's asked common cause and ligament injuries.
We have already discussed.
Yeah.
Yeah.
Yes. Then we have, yeah. Then
Rehab program is also discussed.
Is the rehab program for ACL and MCL same or different? Yeah. Then we have by
It's
Dr.
obvious to ask, like, because we don't know what is the function of each muscle. Okay.
Right.
Medial collateral ligament supports in mediolateral. It is for valgus varus. Okay. ACL, as I was highlighting, all the three directions. So how the rehab program will be similar. Okay. So the whole plan of management depends upon the role of the ligament. Okay. Hero's friend who is meeting with an accident versus hero meeting with an accident in a movie, totally different. Okay. So MCL is like that. It's one of the friend for the ACL, but it does not mean that rehab will be together. Okay.
Right.
Even in combined injuries, my goal will be to see whether ACL injury is primary, because ACL has that multidimensional role, okay, to stabilize. ACL has that delayed recovery, that chances also, because if the blood vessels inside the ACL is torn, it will not heal. So that is why surgery and reconstruction is done. Okay. So remember that rehab will never be same, even if it is the MCL itself. In the same patient, right MCL and left MCL, both are grade 1 also, or both are grade 2 also. Okay. AOMPT will ensure you to make you understand that one is paining in the supine lying, another is paining during weight bearing, means their rehab will be different. Okay. So this is what I was highlighting. Okay. So it's not just about the name of the ligament. Even if it is the same ligament also, rehab will be different. Okay. And today's rehab will be different from tomorrow's rehab. Okay. So this is something which is important, right? Because it depends on the functional level of the subject. If the subject is not able to do the functional activity, do not use that functional training. Okay. If the subject is doing it very well, the previous day's one, go to the progression. Okay.
Yes, sir. So then we have a question by Dr. Charmi.
Yes.
She's asked, if ACL is dissolved with meniscus, then what will be rehab strategy?
The rehab strategy will be this only. Okay, where is the symptom? Which functional activity is affected?
Yes.
So I think all the structural questions we can skip. Okay. Because even if it is meniscus injury, or it is collateral ligament injuries, or it is ACL injuries. Okay. Of course, for meniscus, my emphasis will be rotations. Okay. So I know that rotations are the important one for meniscus. I should know that. Okay. And the same way, it is the abduction, adduction, or valgus varus for the collateral ligaments. Whereas for the cruciates, it's the anteroposterior translations. So these things I should maintain. But the functional symptoms only is more important for me. Okay. So see that where you are putting the tape, how you are putting the tape will determine by the function of the ligament. But afterwards, the rehab patient who's having pain on stair climbing, you are going to train the stair climbing only for all the three. Okay. But your emphasis will be on anteroposterior translation if it is the cruciate ligament injuries. But your emphasis will be on rotations of the tibia if it is the meniscal injuries. Your emphasis will be on the valgus or the varus, the knee, if it is the collateral ligament injuries. Okay. So ultimately, you are going to train the same, but your emphasis will be different for different ligaments. Okay. So strategy will be the functional strategy. Okay. Not the structures or the extent of the injury. Okay. Because in any of the literature or evidence, if you are seeing, nothing was able to correlate any finding. Okay. Even in athletes or in sedentary people, they could not find a clear relationship between grade 1 injury, what is the findings in the other pictures. Grade 2 means what is the picture in the other, anything, nothing they could find anything. Okay. So finally they concluded that it is biopsychosocial. Okay. This is the sports journals. Okay. Including the American Journal of Sports Medicine. They all know that the structural classification of injury is only for structural or for documentation. Okay. For surgery and for documentation, not for clinical recovery or clinical assessment findings. It is not like grade 1 injury has a minor deficits of muscle weakness. Grade 2 means more muscle weakness. Grade 3 means marked muscle weakness. Never. A grade 3 injury patient can come with excellent muscle and motor control also. Okay. So there are exceptions in every spectrum. So that is why focus on functional activity versus structural and static and dynamic loading. Okay. So
Right.
then you know that repetitive loading or overuse. Okay. That is the last stage. So that will
Yes.
be the strategy for rehab. And every progression, when I am progressing from static to dynamic, when will I progress? Definitely there should not be the joint effusion. There should not be tenderness on the ligament. Okay. So these things and the symptom should be constant to intermittent. Okay. So when the symptom changes intermittent, then I can go to dynamic. If constant symptoms, why will I do a static to dynamic progression? Okay.
Right.
So remember that these things go as a clinical reasoning, which is common for all of us as physical therapists. Okay. Respecting the patient's symptom. But at the same time, too much you give emphasis to the symptom and you decondition the patient can never become normal. Okay. And you might give a brace because you are getting commission from the company. You might refer the patient for surgery because you are getting commission from the orthopedic surgeon also. Okay. You might refer the patient to MRI because you are getting commission from the radiological testing center, diagnostic center. Okay. But that's not the treatment. Okay. You as a human being, when you're taking care of another human being, ensure at your best that if I am a patient, how would I like to be treated? Okay. So
Yes.
that should be the actual translation into practice. Okay,
Right.
when it comes to rehab, not the protocols or day-wise progressions. Okay. So don't expect that in our course. Okay.
Yeah.
After 3 weeks, you can progress that. After 3 months, you can do this. Okay. There are patients who can respond favorably. And if you are actually able to correct the what is called as the multifaceted dysfunctions, okay, the compensations, okay, because body is trying to compensate for a ligament injury. It will try to compensate with capsule, or it will try to do with tendons or muscles which are nearby, okay, or it will take compensation into other joints, okay, hip or ankle if the knee is injured. So these things only are important. That compensations, whether how much it helps the patients. Many of the patients are asymptomatic because the compensations are successful. So they are symptomatic only when the compensations are inadequate or they become too much compensating. So the other regions become symptomatic. Okay? People have ankle injuries and they come with ONE. Okay, medial best answer in tendinitis of the knee because lateral ankle instability is there. Okay, so whereas moment is created with inversion of the ankle. Okay, so it's compensation. Knee was trying to compensate for the ankle and the knee becomes symptomatic because it's too much compensating. Okay, so these things and all has to be evaluated in the patient, not the what is called as the name of the injury, okay, or the stage of the injury. Okay, in rehab. Right.
Right. Yeah. Then we have a question from Dr. Roshni. She's asked, how will we get to know that it's an injury, anterior or posterior?
As we were talking about the mechanism, yes. Next.
Next question is by Dr. Shreya. How to know that it's an ACL or PCL injury?
Oh, again, it's the same. Okay.
Yeah. Yes.
See, for example, anterior translation of tibia, that means it is like I am running, I suddenly stop, my foot stops. Okay. Body goes anterior, femur will go anterior. So that means it is posterior translation of tibia. At the same time, standing, I am trying to run, initiating, acceleration versus deceleration. Okay. So deceleration injuries will lead to PCL loading, whereas acceleration injuries will lead to ACL loading. Okay. So rotations also, internal rotation, external rotation for ACL and PCL. We are unable to find, for example, if Amitabh Bachchan and Shah Rukh Khan both are acting in a movie, how do we know that who is the hero? Both are there in the movie. How do you know who is the hero? During the name itself, it comes. You can know who is the hero. Hero's name, how it is put. First, whose name comes? Amitabh Bachchan, in and as. And then the movie name comes, means he is the hero. Although he might come only 5 minutes. Other 50 minutes, Shah Rukh Khan is doing this in the movie. But he is not the hero. Because the first what is there, that is the one which is first important. Okay, what is given importance by the director. In this situation, it is the mechanism of injury or the time or the god, whichever you want to call. So if ACL and PCL, so what is the role of that ACL and PCL? Okay, how important they are. Definitely you can know that why the activity itself, anterior translation of tibia or posterior translation of tibia. So which one? This is totally opposite. So easily you can tell which is the injury. Okay. So we are asking, we don't know because we have not watched the movie. So I will ask that who is the hero? Amitabh Bachchan or Shah Rukh Khan. Okay. So if I am watching the movie, I should start from the beginning till the end. Because in the end also, if somebody dies means another one is alive means the alive person only is hero. Because hero never dies. Okay. So this is another psychology in our Indian Bollywood. Okay. So same way, from the beginning till the end of the picture, it's important. Okay. Right from history where the mechanism of injury to the recovery and how well the patient can come back to near normal function. Okay. So everything will tell what is primary and what is secondary. Okay. Whether it is the ACL or the PCL. Okay. So don't think in terms of just doing an anterior TRAR or posterior TRAR will tell you ACL injury or PCL injury. Okay. Right.
Yes. So then we have a question from Dr. Pranali. She's asked, what are the major precautions should be taken for athletes to prevent ligament injury?
Major precautions are to do with their schedule of their training. Okay. What is called as the periodization programs. Okay. You are more concerned about when the competitive game is coming. Okay. So what is their target? The subject has to participate in a high level competition in 3 months, or is it really possible for 6 months? Okay. So that timing, that is important. And the next one, in each day, how we are going to individualize according to that athlete. Okay. And they should feel interesting, and they should also feel that the training program matches with the game performance. Okay. Any of the training program is just not for muscle training, it is performance training. Okay. So like that you should include, then only the athlete will be interested in doing it. Okay. And your injury prevention strategies will range from footwear, or it is taping or bracing. Okay. And also into the repetitions. Okay. Because too much, sometimes now the whole evidence has got shifted now that no need for stretching as a warm-up. Okay. So warm-up, if you give stretching, means it is more harmful than doing benefit. Okay. So this is a confirmed evidence. So these things which might be in their mind that I should stretch. Okay. You might tell them to do the cycling. That is a better warm-up. Okay. You can get the better blood circulation, and you can get that joints and muscles to get moving. Okay. More flexibility will be better than stretching. Okay. So physiological warm-up is much better than the physical warm-up of stretching. Right. So these kind of things, again, the psychological aspects there will influence the recovery. Okay. So make sure that it should mimic the game. Okay. If it's a bowler and you want to give a shoulder injury rehab, okay, even if he's in supine lying, I will ask him to do the bowling action only. Understood? Although he is not standing. Okay. Whatever way is limited by the plinth, I will see the possibility, not the obstacle. Okay. How you can do bowling lying down in supine? Just let him move the leg, let him move the arms. No problem. Let him be in supine. But I'll give the training in supine itself the same functional activity, which is important for the subject. Okay. So the rehab totally is different. It's unimaginable. Okay. What you are going to actually think of. Because that is what the brain is being adapted to. The brain is been knowing that, yes, I am a fast bowler, I am a fast bowler. Okay. So that is what will make the patient to recover faster also. Be compliant with your rehab also. Okay. So I will see that when he is doing that bowling action in supine itself, whether the shoulder is getting affected in any part of the range, okay, whether can I help it with MWM or it is going to be with TheraBands. Okay. So I will not compromise that functional activity which the subject was doing. That will be my first phase of rehab. Okay? To make sure that the patient realizes if the affected side shoulder he cannot do anything, I will at least tell him that use the other side and you bowl in supine line because crossover effect of the training. You're understanding what I'm trying to tell? Okay.
Yes.
So functional is functional. Okay. Never compromise that. Yes.
Yes. Then Dr. Manjula has asked, can partial MCL injury repair by itself?
Anything and everything can repair by itself.
Yeah.
Okay. What you are talking of repair is two types of repair. One repair is structural repair, another repair is functional repair. Okay. Structural repair, surgery. Okay. Functional repair, body's adaptive mechanism. My muscle control, my balance, my proprioception, my level of activity, and my descending inhibition. Everybody can get cured. Okay. So remember that it is not a repair, it is a recovery. Okay. So subjects are able to do the same functional activity and they're able to participate in that level of expectation to match their own goals. That means their recovery is complete, although if the ligament is not united. Okay. So think of that aspect. Okay. Functional. Yes.
Then we have a question from Dr. Roshni. How will we get to know that the treatment is going good? What's the sign?
Treatment is going good only by the improvement in functional activities. Okay. So if the continuous pain becomes intermittent, treatment is going good. If the intermittent pain is becoming less in frequency, treatment is going good. And don't go by intensity of pain, okay, because it will vary between every episode. In a day, if I get 10 times pain, once it might have been 9, another might be 4. It's very difficult to ask a patient and they will tell that it is 6. Okay. So you cannot keep an intensity as a measure. Okay. And then if it is pain, if it is clicks, then I will think of whether clicks are coming with the open kinematic or clicks are coming with closed kinematic. So that's what, again, the static and dynamic and structural to functional. Okay. If a patient is doing only movements in open kinematic, but the next day it's become intermittent and he is taking the closed kinematic, means it's an improvement. In the closed kinematic, weight bearing was not possible that much. So I kept the knee in the front, leg in the front, and then I was doing as lunging forward than the squatting. Okay, actual squatting. So I kept the leg in the forwards and then I did the squat. Okay. Next day, I'm able to keep the foot a little bit behind in alignment with the body. Okay. That is an improvement. Okay. So if the concern for the patient is squatting, then coming towards the normal squatting is an improvement. If the concern for the patient is running, then coming forwards is an improvement. Okay. So keeping the foot forwards or keeping the foot backwards, which is an improvement, depends upon what activity is important for the patient. According to the patient's goals, if your progression in therapy is there, it is an improvement. Otherwise, nothing is an improvement. You might tell range of motion has improved. You might think that the translation is less. Okay. You might think that swelling has reduced. That is not at all improvement. Patient will tell, I am not able to keep my foot on the ground. Yesterday also, I was not able to put the leg on the ground, weight bear. Today also, I am not able to weight bear. So I am not improved. The patient will tell. So that is why I am telling, treat the weight bearing. So that is where you are actually creating a difference in a person's life. Okay. This course is a very, very important course. So tomorrow, what we are going to have, it will break all the existing practices. Okay. We were actually becoming instability in our rehab. Okay. In our thinking process. That I am going to make sure that it comes to the, what is called as the recovery. Okay. So that is the plan of this course. And even any of the spinal instability courses, the master classes also, you would have seen that how we are addressing that instability is totally different from what we have ever imagined. Okay. Spinal, any disorder can cause instability. Okay. Radiculopathy can come with instability. Myofascial pain can come with instability. Same way here also, ligament injury can come with multiple dysfunctions. Okay. So it's always important to functionally make all the tissues to work together, and the functional activity should be the target rather than, hey, ACL injury has happened. Hamstring, you are ready to work. Medial hamstring, lateral hamstring, who is ready to work? Quadriceps, VMO, vastus lateralis, rectus femoris. I am not going to ask one by one and then choose which one I can give the rehab. Okay, human body is not that. At the same time, quadriceps is working, hamstring is working. You cannot even isolate any of these muscles. Where you will isolate VMO? Huh? This kind of literature, what is there? Vastus medialis obliquus rehab and then patellofemoral instability. It's all kind of what is called as hypnotizing. Okay, people towards one particular thing. Okay, narrowing down the thinking process. Okay, rather functional is diverted into a regional one muscle which will be absent in 90% of individuals. Okay, so where you are going to do what? Okay, so and finally you find after all the VMO strengthening and we do all the things in our literature, rehab, everything, textbook, everything, it comes. Finally, you find the literature stating that VMO is absent in most of the subjects. Okay, and then other literature tells that VMO is not actually a muscle; it is a fibrous expansion. That's all. It cannot shorten and lengthen. Then what you were doing with VMO all these days? Okay, no problem. Okay. Next, we'll go to next confusion.
Yeah.
Okay. Something new thing we can choose and then we can get confused or misdirected. But remember, functional is always functional. It will never change. Okay. So, and it will always create a difference in people's life. Yes, Dashna.
Right, sir. Our next question is by Dr. Manjula. Strategy to rehabilitation of MCL injury to come back to normal daily life activities.
So what I'm telling, whether it is PCL or MCL or LCL or ACL. Okay, the study materials, I have given all the testing, okay, for the course participants, tomorrow's course. You are given special test also, you are given all the clinical picture individually also, all the theoretically what is there. But the rehab will be functional. Okay, so next.
Yes. Then the next question is, there's no name. Is it possible to treat conservatively a grade 3 ACL injury? Yes.
Again, okay.
Yeah.
So ACL cannot be conservatively managed, but sometimes if it's elderly, you don't want to take a graft of patellar tendon, or you don't want to, you find that the graft also will be less vascular. Okay, so what is the point in taking and reconstructing the ligament? Surgery will immobilize the patient at least 3-4 weeks. So you might do a brace and then mobilize. It is like an elderly patient who has a fractured neck of femur. You just replace that with hemiarthroplasty or whatever, total lipoarthroplasties. In the aggravated cases, you just leave it to become avascular necrosis, let it be pseudoarthrosis, let it be fibroarthrosis, and mobilize the patient with walker. Functional walking is important. Activity is important for the elderly. Okay, so that is the geriatric rehab. So there are spectrum of patients where you can compromise. Surgery is not needed if the functional demand is not much. Okay. But if the functional demand is more and the subject is young and you know that other injuries might come together, definitely surgery is indicated.
Right. Yes. Then we have a question from Dr. Anisha. She asks, what is the common cause of the injury? On what basis can we decide the rehabilitation program? And what are the preventive measures for reoccurrence? It's almost the same.
Preventive measure for?
Reoccurrence.
Reoccurrence. Okay, this we covered. What was the first half, the first sentence?
What is the most common cause of injury?
Common causes of injury means it is like, we are not expecting a direct cut injuries. Okay. Ligament injury, cut injury, these kind of injuries can happen in upper limb. Okay, sometimes. But there again, your emphasis, indirect injuries are the sports, what we were talking, open kinematic, closed kinematic. Even degeneration after that injury can come. Connective tissue disorder, then injury can come. Okay, so all this which we talked. Yes, next.
Then we have a question from Dr. Charmi. Asked, how could we know that its ligament injury is first grade or third grade?
You don't have to know whether it is first grade or third grade. Okay.
Yeah.
If the pain is less, it must be third grade. Okay. complete tear, because pain will not be there, because there is no fiber that is intact to actually create the pain. Instability is pronounced, as I was highlighting. In the instability masterclass also, we had an interaction previously. Okay. In that, I was telling you about that what is called as laxity, hypermobility,
Yes.
and then instability, then subluxation, then dislocation. Okay. So this progression is more faster if it is a third degree. If it is first degree, mostly it will not progress to the next level that fast. Okay, to subluxation and dislocation. So remember that that does not matter at all for our rehab. What is important here to see the functional improvements. Okay, functional problems. That is the one which is most important. Okay. Next.
Yes.
People who feel that you want to learn better, please enroll in the course which is starting tomorrow. Okay, that is the most important fact here. Because I know that there are 100+ participants who joined the group, whereas only 40+ participants or 50+ participants actually registered by informing me, and we see that 30+ participants are attending live. Okay, so people will get the certificate if they ask the question, but people will get the knowledge only if they enroll in the course tomorrow. Okay, so always remember that, don't keep asking the same question to repeat or to explain again and again. Enroll in the course if you find that information is valid. If you have a technical difficulty with today's session, which it is like beyond the human control, okay, you got an interruption, you could not hear what I was talking, it could be possible. But remember that you are an AOMPT member, you will get the link of today's recording. Okay, if you are not an AOMPT member, you are nobody for me, because you know me. If you are attending first time, this is the first session which you are attending today, maybe I can think of, but still I will feel that your friends are not at all sincere, because till now they have not told you about AOMPT means. They are not bothered about you at all. Your colleagues or your friends or juniors, everybody. Okay, so you are knowing AOMPT now only as a physiotherapist. You are living with a very bad company. Okay, so first change that. That is the first solution. And remember that when you are knowing it and you know that we are having a valuable discussion, you know that every moment, every minute what you are spending here is valuable, means same multiplied value, exponential value will be there for tomorrow's course when you are attending enrolled. Okay, the study materials also that extent. So everything is a different dimension. So give it that value that it deserves. Enroll in the course, you will get the best benefits. Yes, Darshana, continue. Paramita, you want to ask anything? You can. Dr. Paramita is also our core committee, and yes.
Good evening, sir. Yeah.
Yes.
This course is very valuable to us because instability is recurrent as we go from young age to old age. Young age people who are in the sports, they have instability problem, and as well as the adolescents people who are very sedentary, they have instability problem. And then as we go to the geriatrics, they also have instability problem. So instability is a very prime issue in treatment, and it is not treatable also in some cases also. So we have to be more judicious in how to be recovering functionally, because by emphasizing on motor control and what are the muscles which are actually loading the ligaments, that muscles have to be trained on. So I find that in my clinical practice that these types of instability can be delivered more clinically, but I want more knowledge from your side also, that how can we overcome the problems, especially in after total knee replacement. Also we find that instability is persistent in knee. So that at that moment when the people are spending so much money, and after that also they are not getting the full recovery because of these instability problems. And before joining AOMPT, I was not aware of the lower extremity kinetic chain also. So after that, after attending your course, so the ligaments and which are loaded continuously, even after the surgery also, we have to be more conscious about the lower extremity chain, how it is influencing the total knee replacement cases also. So my question is that how can we actually um, treat these issues in case of so expenditureable surgeries, even after the patient is having so much money drained after such a long surgery, such a long period of time, still they are not able to recover fully. So how can we approach these patients and how can we treat them clinically?
Every approach when it comes to patient means what is important for the patient is always the functional activity. So functional approach is always functional. Whether the structure is altered because of the surgery, be it reconstruction or it is a replacement, you highlighted that functional is important. So functional approach is always the approach. As I was now discussing that the functional activity training will be there even in supine position. If he is running having symptoms, but now having constant symptoms in supine. In supine, I'll ask him to do the running action. You understood or not? What I'm trying to tell is the brain's memory, the central pattern generators, okay, in the spinal cord, the motor recovery, functional recovery. So how we are planning that from central nervous system onwards to peripheral adaptation and compensations. Okay, so it's unimaginable whether you have aquatic therapy or not aquatic treadmill, so you cannot make them to run. So various barriers will be there, but my rehab will always mimic the major activity which the patient wants to do. If it is a TKR subject, what is the important thing? For them to sit and squat on the floor. Okay.
Yes.
But I should be sure that whether with that implant the subject can be doing this or not, because the implants are different types. Imported implants, different surgeons, different expertise. They will tell that you can have even squatting, full squat, you can do floor sitting, and then you can get up. All these things are there. If the surgeon tells no, you can get 120 degrees, but not beyond that. Okay. So definitely you should be careful that you should not create an implant failure by being aggressive in the functional goals. Okay.
Yeah.
So another thing which you should be sure in such kind of a replacement surgeries is the extent of the tissues that are being cut, tissues that are being replaced, whether it is cemented, non-cemented, or whether it is which of the articular surface where any complication during the surgery, any vascularity problems, any bone substance, okay, any osteoporosis anywhere, anything, okay, so laterally it is there, so weight bearing, so that it will create a pathological fracture. So a lot of things, okay, which will have to be discussed with surgeon, okay. But what's important is always the functional approach, and what's important is to match that, okay. If you find that structurally the implant can take only 90 degrees, it is only sit to stand that is possible. Beyond that, the subject should not be allowed to do, because surgeon has told that implant will not take that picture there. Then explaining, counseling, and educating the subject, making them to understand, and making sure that the sit to stand is fully functional, good endurance, absolutely no symptoms. That will be our end point, okay, in the rehab. Okay, so we have to modify the goals according to the what is called as the limitations that are given by tissue replacements or reconstructions. Okay, even ACL reconstruction also subject the surgeon can tell that no, the graft is not that much strong. Okay, we have fixed the graft, but the graft site is not that much strong. So what they tell you have to believe. One important thing is, as patient has spent money and time for the surgery, lack of improvement, they will now tell that what has happened, the surgeon has done so much and still we are not improved, they will tell. Same way tomorrow, don't make them to tell, I went for therapy 2-3 months, still no improvement. Okay.
That also.
So today, if they talk about the surgeon, tomorrow they will talk about you. Okay. So ensure that you and surgeon should be on one side. You think for the patient, you should try to match the goals and set a shared informed decision making. But what's important here is to see that your goal setting should match with the surgeon's actual observation, because they have seen the tissue inside. Although some surgeons are commercial, we can't just ignore the surgeon's opinion, assuming that everyone is unethical. Okay, so and take a full responsibility, because you don't know what the structure is inside. Okay, because they have replaced it. So and recovery post-operative, no surgeon will give the credit to the physiotherapist. Okay, but you don't bother about that. Okay, patient will give the credit to us. Okay, because they know that after surgery they have not improved, but after therapy only they have improved. Okay, so even if they don't give credit, don't worry. Okay, the credit will come in different form in a different time later in your life. Okay, so when you least expect it. Okay, when you are expecting it, it will not come. That is not credit. Okay, so always remember that. Right.
Thank you, sir, for your valuable guidance.
Okay.
Yeah.
I think there were questions on ligament injury, how to find ligament injury, how to differentiate ligament injury from tendon injury. Darshana, you are able to unmute?
Sorry.
Yeah.
Yeah. Yes, sir.
Okay.
Yeah. So many questions on differentiation.
Ligament and tendon injuries.
Yeah.
How to find out whether there is a ligament injury. Okay.
Yeah.
This kind of ABCD questions. Why I'm telling it is ABCD questions is because these are basics of examination. Okay. One thing is ligament, we know the attachments, where to where it is attached. Palpate. Palpate from that attachment to attachment. So if I am getting from coracoid process till the greater tubercle, there is tenderness. Okay?
Right.
It's the coracohumeral ligament. Can't I guess that? But when I tell coracohumeral ligament, if you feel coracohumeral ligament, ye kahan hai? Means you cannot diagnose. Okay? So first and foremost for palpation and diagnosis is surface anatomy. Okay? And if a subject tells here pain, okay, exactly at the lateral point in the shoulder, okay, on the bone, they're telling pain. Okay? So what I should do? I should give compression. If I give compression and if the pain comes, it is the acromioclavicular joint. But if the same is, I am giving movement to the clavicle alone, I am giving pressure on the clavicle alone, and the pain is coming at the shoulder. Okay, so that means it is the capsule injury. So I am gliding the clavicle, capsule is getting stretched, and it is getting painful. Okay, so or distraction also I can give, push the coracoid and push the acromion. Okay, so coracoid will stay together with the clavicle, and acromion will go. So acromioclavicular distraction. So that is painful, capsule. Okay, I block the clavicle and I give pressure on the coracoid. Okay, coracoid process. That means I am distracting coracoclavicular ligament. When I am telling coracohumeral ligament, if you are like coracoclavicular, coracoclavicular, then you cannot diagnose. But if you know the attachments, you can definitely diagnose. And what I am trying to show as a demonstration now in 2 minutes is the functional palpation. So actually we are checking for capsule injury, or it is the ligament injury, coracohumeral, or it is the coracoclavicular. So in one location itself, I can easily tell shoulder ligament injury. That is not diagnosis. This is diagnosis. Okay, and the same way, ligament versus tendon or ligament versus capsule. When it comes to the knee joint, remember capsules always stabilize in the close packed position. Ligaments will stabilize in the loose packed position. Okay, so you have a close packed position and loose packed position. Close packed position is where the joints are maximally compressed. Loose packed positions are where the joints are distracted. Okay, that is the position where ligaments are stabilizing. Muscles where they stabilize. They are not stabilizing in the end ranges. Capsule and ligament, both of them stabilize in the end range. Okay, but capsule stabilizes in close packed position. Ligament stabilizes in the loose packed position. Both are in the end range only. Okay. And if you see for the muscles, they stabilize during the movement, not the end of the movement, end ranges of the movement. So tendons, they are actually attached to muscles. They are between muscle and the bone. So if we know the muscle, we can evaluate the tendon. The action of the muscle, we can evaluate the tendon. And the action concentric means it is muscle belly. Eccentric will damage the tendon. Okay. So tendon injuries are common. One because of blood circulation being less in the tendon, another because of eccentric overload. So tendon injuries are common. In the course, the ligament injury specialist course tomorrow, we are having one topic, the tendo-Achilles tendinitis. Another topic which is medial tibial stress syndrome. Both of them are actually the muscle related. But why have I kept in the ligament injuries? Because they are all associated with instabilities. So whether it's an ankle instability or it is the muscle imbalance related instabilities. When it is ligament or capsule related instability, it is called as the static structures. They are all passive instability. They are mechanical instability. Whereas the motor control related instability is functional instability, which is clinical instability. So that is also part of instability only. And they also maintain the recovery. So it's all interlinked. So that is why if a ligament is there and a muscle is there above or a tendon is there above, you want to differentiate. Tendons are influenced by contractions. So if you palpate and the contraction, it will pain. If you are having supraspinatus tendinitis, you do a empty can position with the thumb facing down in the empty can position and then resist the abduction in the scapular plane. So that means it will be the supraspinatus tendon because I'm giving resisted contraction. If I don't give the contraction and directly I palpate superiorly, okay, or the contraction is relieving the pain because here contraction is there, I am palpating. Here the ligament is injured. Okay? Contraction is relieving the pain because ligament is injured deeper to the tendon. So if ligament is superficial, it will be palpable tender. Contraction will not alter the tenderness. A ligament that is deeper to the tendon, contraction will relieve the tenderness, even if it is ligament injury. It is like medial collateral ligament and pes tendon in the knee, medial hamstrings. So if you are resisting the medial hamstrings and if the pain is getting relieved, you should know that it's a deeper structure. It might be the medial collateral. Medial collateral valgus. Medial collateral, medial epicondyle to medial epicondyle, femur to tibia. Whereas pes tendon is from the pes tubercle, the medial tibial condyle, all the way till sartorius, semitendinosus ischial tuberosity. Sartorius is ASIS. Okay? Semitendinosus is ischial tuberosity. Gracilis is to pubis symphysis. Okay. So remember that these muscle attachments, if you know, you can differentiate the tendons from ligaments. Even in pes tendinitis, it's important to differentiate between sartorius injury, or it is semitendinosus injury, or it is the gracilis injury. Otherwise, you are not a physical therapist. We are so proud that we learned biomechanics. But what we learn in Cynthia and Argent is only anatomy. And when it comes to physical examination, the pathomechanics is never addressed at all. People tell pathomechanics, and they tell normal mechanics. Okay? So that is the problem there. So when in AOMPT courses, the pathomechanics is given totally in-depth importance. Okay? We see that in every course, every disorder, we saw the pathomechanics. Without pathomechanics, there is no evaluation, there is no treatment. So that's the reason it is worth your life trying courses of AOMPT, because Your life before AOMPT and after AOMPT, it will change. And it will change for the better. That is the difference what AOMPT can create in your decision making and in your professional domain. But if you ask our core committee members, they'll tell the last 1.5 years, they're doing like a master's program only. It's doing like another MPT program for them. Okay, doing all the online courses, everything of the AOMPT. But they will also tell that as a person also they have changed. Okay, it's not just as professional domain. As a human being also, you definitely become a better person. Okay, because even today's explanation, what you have heard incompletely here and there scattered also, you would have known that this information definitely it's a big take-home message. Okay, every sentence what I tell. It's not my greatness, it's the greatness of knowledge. Okay, I always tell, we are just doing our duty best to think the best for the people. If you want to really do the best for people, automatically all the best things will come to you. You cannot give light to others unless you are glowing. You just be ready to give light to everybody. Just be ready. I should give light, my best light to everyone. Be ready. He will make you bright. Don't ask him, make me bright, make me bright. Understood? You will automatically become bright if you are giving your light to everyone. That is how the knowledge sharing is there in AOMPT. So do not postpone your decision. Join the courses. This course also comes with the bonus package of the double practitioner taping, rigid taping, the certified therapeutic taping practitioner course. That is also full materials with certification is free. So it's a buy one, get two offer. Okay. So you will never get this kind of an offer for this fee and with lifetime membership of AOMPT where you are going to get future access, everything, regular updates, all the discounts, everything, okay, in every course. Do not miss that chance, right? Continuing with Dr. Darshana always thinks, she thinks too many questions are there. We should go to the next question. Okay? She's more into that organizational responsibility as a general secretary. Don't worry, okay?
Yes.
Remember one thing, as we are having interaction means we can address queries, we can develop the concepts, okay, thinking. The way I am describing itself, it would have cancelled all the structural questions.
Right.
Okay? And then we are talking about differentiation here. So, be it bursa is painful on direct compression. Okay? Other than that, bursa you can never check. Okay? Direct tissue compression only is bursa, but with the compression and contraction. So, if I am checking olecranon bursa, that means with compression and resisted extension of the elbow. Okay? So, triceps, because I should know triceps tendon is the olecranon bursa. It's the best answer in bursa. So, these anatomical knowledge there gives you an idea for what are the associated injuries. Okay? You cannot just think medial collateral ligament injury. It can be pes answer in tendon or it can be the pes answer in bursa.
Right.
And the patient could be just a osteoarthritis of the knee. You will think that it is a medial joint line tenderness. No, joint line tenderness is horizontal, collateral ligament tenderness is vertical.
Okay.
So this is something which is a very, very bottom line differentiation. But we need to do that. If you don't do that, you are not a clinician, you are only a technician.
Right, sir.
Yes,
Yes. Then we have a question from Gabby. What about McKenzie or Mulligan methods for ligament injuries?
Yeah.
Yeah.
McKenzie may not be advisable, mainly because it is talking about the passive movements and then end range positions and then centralization, peripheralization, okay, all these things. McKenzie is useful in periphery for arthritis, okay, restricted range of motion. Okay, so there's a stiffness. So ligament injury after reconstruction, you can use McKenzie. Even like how Madam told TKR, you can use McKenzie, no problem, because we use that for posterior capsule stretching. Okay, flexion deformity of the knee after TKR. Okay, prone, we can put that leg hanging with the sandbag, we can give the extension. Same way in supine also, we can, or sitting also, we can use the McKenzie's knee extension. Okay, so, but the primary goal These are all structural treatments. When you are treating McKenzie alone means structural. But when it comes to AOMPT, we have extended the McKenzie approach, the mechanical diagnosis and therapy, into mechano-functional diagnosis and therapy, which is again like Mulligan, I have already told that you can use. Okay. So initially itself, I told that during functional training will be the goal. During the functional training, if there is symptom means, give the Mulligan. And I told the example of lateral ankle sprains, giving mobilization to talus or giving mobilization to the lateral malleolus. Okay. So these things goes without saying. Mulligan definitely will help, but remember that how long, okay? And with what training we are incorporating together. Okay? In other methods, in other conventional methods, what you are treating till now, you might do the Mulligan separately and then you will give the exercises separately. But in AOMPT's instructions, you will give the Mulligan together with the strengthening, so that the strengthening activity becomes painless.
Yes.
So that is how it is called as the functional neuromuscular stability training, FNST. So it's a higher level of neuromuscular training, incorporating balance training also. It can be on wobble mode or foam or physio ball. So it's something which you have to definitely explore towards improvisation of your knowledge. Okay. Right?
Yes. Our next question is by Dr. Akhtar. He's asked how to diagnose it, ligament injury or tendon or other injury, which you just explained.
Yes.
Next question was by Dr. Roshni. What's the first stage of rehab?
I already told functional. Okay.
Yes. And by Dr. Pranali, in cricket, which ligament injury is very common?
It's not as per the game. Okay. A wicket keeper may not get any injury at all. Okay. So he will get only the ulnar collateral injuries in the wrist. Okay. Very rarely, or thumb ulnar collateral ligament injuries. Okay. The carpometacarpal joint thumb. Okay. So ball hitting the thumb. Okay. So that kind of injuries are falling, this kind of injuries. Even in falling also, medial collateral injuries can come, upper limb or outstretched hand. So remember that the role of the player is important. Throwing will create different set of injuries. Okay. For fielders, for a bowler, the landing leg will create injuries. Okay. For a fast bowler, and spin bowler, it will create upper limb, the throwing arm, that injuries. Okay. Spin bowlers. A batsman can get ligament injuries in the upper limb. Okay, which is because of the bat. Okay. And if they have a poor flexibility in the lower limb. And running time, they can fall, they can slip, and anyone can get any injuries. Okay, whether it is ACL or it is lateral ankle sprain or it is. So remember that it's not related to cricket. It is related to the player, their role, and the mechanism of injury, the footwear, the condition that time. Okay, what might lead to the injury. So every injury is common in cricket. The same way every injury is common in football. If you ask which ligament injuries are common in football, I'll tell goalkeeper will get only upper extremity injuries. Okay. So goalkeeper will get the injuries because of ball hitting him. Okay. But not otherwise. Whereas the other persons who are forwards versus defenders will always get injury because of combat injury. Another player coming and hitting them. Okay. Forwards, it's about what is called as your own agility. You must be very aggressive in movements. Okay. So you might, even somebody gives a perturbation, you can fall, lose balance and get injuries. Okay. Your own body weight, which is more common among the forwards. So everyone gets the injury. But what is the player, what role they are playing? Okay. So you don't ask ligament injuries in cricket means what are the ligament injuries? No. Okay. Your focus should go to the player, not the game.
Right, sir. So then Dr. Shreya asked, how to know the grades of ligament injury?
Already discussed.
Yeah.
Okay.
Dr. Amir Shah, he's asked, will my torn ACL cause arthritis?
Yes, already discussed.
Yes. By Dr. Pranali, she's asked, what will be the rehab strategy for shoulder ligaments?
Every rehab strategy for every ligament has been already told. Shoulder also, I told the example of bowling means how functional strategy. Yes.
Right. Dr. Roshni, she's asked, how will we strengthen the ligament? or how to strengthen the ligament?
Okay.
Hmm.
This is what I am trying to tell. Okay.
Yeah.
As initial stages, you want to give a compensation mechanism by training the muscles. But in the middle stage, you should directly load the ligament, which is like reorienting the fibers of the ligament, maybe by a deep transverse friction massage. Okay. So that deep transverse friction massage will reorient the collagen fibers during the phase of healing, so that the ligament is prepared to take the loads. And subsequently, it is optimal loading. Progressive loading is also important. So the ligaments have to be loaded, okay, as per the actual mechanism of injury, which was once upon a time. In the functional and close kinematic, we should give the same valgus forces. We should ensure that the medial collateral ligament becomes stronger, okay, by that same loading. Because every structure gets stronger only when it is functionally loaded as it was supposed to be earlier. Okay. So even in ONE, osteoarthritis of the knee, the late phase, always the intermittent compression of the joint is important. Initially, compression was painful, but later we need the intermittent compressions. In the initial itself, sustained compression was painful. Intermittent compression will improve the nutrition to the joint. Okay. So always remember that walking is advisable for ONE, even if they have pain in the knee because of standing. Okay. So same way, optimal loading should always be considered. If forward walking is painful, backward walking is useful. If backward walking also is painful, do sideways walking. Don't stop walking. Understood or not? So wherever intermittent loading comes to ligaments also, then only ligaments become stronger. If there is no loading, no ligament will become strong. Just by immobilization and protection, ligament will not become strong. It is only by graded exposure to stress we become strong. Okay.
Right.
Dr. Darshana, what you will do is Dr. Roshni's questions you will skip, because if she has more than 10 questions, we cannot keep answering only one individual. She should join the course. Okay.
Okay.
And ensure that they get that further learning.
Okay. Then we have question by Dr. Pal. He's asking a popping sound when the injury occurs, MCL injury recovery time. Okay.
Popping sound means a complete tear. Okay. Recovery is not determined by the time duration. Recovery is determined by the functional improvement. Okay.
Yeah.
Functional improvement can come faster in an individual who is already physically active. Functional improvement may be delayed in an individual in a sedentary people.
Right.
Okay. So functional improvements can come if functional treatments are started initially itself. Then functional improvement will come faster.
Yes.
If functional treatments are not at all taken, functional improvement will be delayed.
Right. Yeah. Then Dr. Shreya's asked,
recovery.
Dr. Shreya's asked, can loose foot ligaments cause bunion?
What is that? Foot ligaments.
Can cause bunion.
See, bunions are because of pressure of the bone on the footwear or the surface, and they develop more and more bone formation there. Or the soft tissue becomes more harder, thickened, hypertrophied, and it may be a soft bunion or a hard bunion. Okay. So these bunions, they are structural problems. Okay. Ligament instability causing a bunion, very rare. Okay. Hallux valgus, great toe deviated laterally. If hallux valgus deformity is there,
right,
immediately the metacarpal head is getting the pressure because of the hallux valgus. Here the pressure is coming. So because of the pressure, getting a soft tissue bunion possible. Okay. But still it is to do with the direct pressure than the ligament. Okay.
Right.
Associate the ligament injuries with bunion. Okay. One is hypermobility. The other one is abnormal weight bearing or pressure distribution in sedentary. Okay. Sustained loading. Okay. So that is bunion. Okay.
Right. Then Dr. Akhtar has asked, is price treatment essential for ligament injuries? And which common ligaments are injured in football and cricket? Yes, which you already answered.
I will say, if you want to give essential, because I already told that these treatments are not needed. Okay. But in patients who are supine and then moving the joints and they have difficulty, they have symptoms of pain, definitely you can combine this because it is restricting the functional treatments performed in supine. Okay. So that time you can give. Okay. So otherwise it's not needed. As I was telling, the role of taping or compression bandaging also. Put taping. Taping is actually gives the support. Okay. So, but it should be for the functional training rather than just supporting the ligament. Okay. So
Yes.
you can use this, but it is not like you use the prices, then after that, next you go progression to functional. No, you use the prices to help the functional training. Okay.
Yes. Then Dr. Shreyas asked, what kind of foods help weak ligaments?
Food helping ligaments. Okay.
Hmm.
Please don't deviate. Okay. If you are thinking of nutrition, means nutrition will not help unless and until you are maintaining that what is called as for a long time, minimum 6 months. Okay. And combined with a good physical activity routine in your lifestyle. Okay. If you are, whatever food you are taking, it will not go to the structure to help the heart. If you want to take a good cholesterol oil, okay, and that oil has to help your heart myocardium, okay, or the cardiac circulation, the coronary circulation. If that is the case, just taking the oil will not help you. That oil in the food combined with your active lifestyle only will help you, because that oil has to reach the coronary artery through its circulation. Okay. So then only it is going to get that block being released. Okay. Thrombus getting dislodged, because it is, that physical activity only will bring you there. Okay. So don't emphasize more on the nutrition. Don't become a dietitian. Don't try to intervene in factors which is beyond your control. Okay. What we actually advise is a good balanced diet. Okay. But if you find that the patient has magnesium deficiency, then we might tell magnesium supplements. Okay. Which might help in what is called as ligaments healing to be faster. Zinc also might help. So these kind of things don't get commercially driven, because there are products and they are publicizing that magnesium and zinc will help ligament strength. So give magnesium supplements, zinc supplements, and you become a distributor holding this, these bottles and telling that take this protein powder, take these things, that things. Okay, please. Okay, you concentrate on your domain and make sure that balanced diet will help. What is balanced diet for one subject is different from another subject. If the level of activity of the subject is good, he can even take high cholesterol diets, because he is having the energy expenditure for the energy demand. Okay, supply, demand. So that expenditure is matching, means he can take even sweets every day. There's nothing wrong in taking any kind of sweets, even if it's a diabetic. If he is physically active, means sweets also will not create any harm. But if it's a sedentary individuals, regular, normal, what is called as simplest thing what I can tell, a lime juice will be harmful. Understood or not? So think of not generalizing, okay, not actually getting into a conclusion. See for the individualized one. That is where patient-centered prescription comes. Okay.
Yes.
Don't think of zinc supplements or magnesium supplements or directly. Yes.
Right. So then Dr. Amir has asked, ACL reconstruction and lateral extraarticular tenodesis, when and how often?
This is the surgeon has to answer. Remember, there is nothing in terms of surgery as an indication itself. I was telling you the criteria. Okay. Then the surgical procedures. Okay. Why they do a lateral tenodesis? Okay. That means what tenodesis they are doing. Okay. Whether it was the valgus deformity to correct that what they are doing. Okay. Or it is a varus deformity to correct that they are doing. So patient has an arthritis with an ACL injury. So they have performed the varus tenodesis. So it is only the surgeon can answer. Okay. You need not think that these kind of things are done everybody. Never. Okay. Earlier question also came, is surgery is the only option for all the ligament injuries? No. Okay. I have already answered that. So tenodesis and all, it's done only in neuromuscular injuries. That means like cerebral palsy. Okay. Or you see for poliomyelitis. Okay. So this is modified tendon transfers there. You just transposition the tendon to another area of the bone. Okay. For deformities, fixed deformities of the knee. So if there is a flexion deformity, I can do the tenodesis of the biceps femoris to tibia. Okay. Anteriorly. So it will become an extensor. Okay. Overactivity of biceps femoris. Okay. Okay, so flexor spasticity is there, but it is contracture, flexion contracture of the knee. I want extended knee for my functional activities, so I can. I will not do that, but if the surgeon does, okay. So remember, okay. So otherwise, you don't do tenodesis.
Right.
Yes.
Then Dr. Charmi has asked, does spinal ligament injury cause spinal injury?
Ligament injury means spinal injury only.
Yeah.
See, spinal injury means bony injury, fracture, capsule ligament injury, instability with dislocations or listhesis. And of course, you come to muscle injury also is spinal injury only. Okay. And nerve injury, radiculopathy also spinal injury only. Okay. Everything that is structures attached to the spine, whatever type of injury is a spinal injury only.
Yes.
Okay. Understand the terminology that spinal injury does not mean only vertebra injury. Okay. It is not the bony injury alone. Muscle injury also is spinal injury only.
Right.
Yes.
Then Dr. Kameshwari has asked, so what is the ideal time to start moderate rehabilitation following ACL reconstruction?
As I was telling the subgroup that moderate, the minimal one. So that means regular activities, paining, daily activities, functional, it's paining. So that is the stage when it is moderate. Okay.
Yes.
If it is at bed, open kinematic chain activities are paining means it's not good for the moderate loading. Okay. So it is that where the MWM comes in the picture, okay, where that strengthening also in closed kinematic chain, everything, squatting pain, but I kept the leg forward, kept the leg abducted, kept the leg backward, whichever I said, all are moderate. But if the same is stair climbing, after 100 steps or 500 steps, after that I'm getting clicks in my knee, and that clicks are associated with the pain, then it is a overuse one. So then I can go for advanced loading. Okay.
Right. Then
Minimal loading comes when subject is having symptoms in non-weight bearing, open kinematic chain.
right. So then Dr. Manisha has asked, any grading for ligament injuries?
I have already told that the staging classification, okay, functional classification, static dynamic in open kinematic, static dynamic in closed kinematic, and repetitive loading. Okay,
Right.
that is all. I don't go behind the first, second, third grades of ligament injury at all. Okay.
Right.
Yes.
Then Dr. Pal has asked MCL injury recovery time. This was you.
The same question I already mentioned.
Yes. Dr.
Recovery
Harish.
time depends what are the factors and everything. Yes.
Yes. Dr. Harish has asked, if a patient does not want to operate third grade ACL tear, is it possible to treat without surgery with physiotherapy?
Same question came. Can we treat the ACL injury third degree conservative? Okay, we have answered.
Then Dr. Tashrifa has asked, what will be foremost technique for rehabilitation of cervical and back ligaments?
Rehabilitation of ligaments.
Yeah, cervical and back ligaments.
Back ligaments. I think this person must answer that which are the ligaments. Okay, it's a very vague question that spinal ligaments. You should know which ligament first. Okay, whether it's the anterior longitudinal ligament, no need to give treatment at all. Posterior longitudinal ligament, whether it is associated with posterior annulus, disc injury it is. If it is ligamentum flavum, then whether it is associated with any kind of a dislocation or fractures. Okay, because ligamentum flavum injury will never come isolated without the fracture dislocation.
Yes.
If it is capsule injuries in facet, then whether it is because of degenerative facet injury, or it is because of traumatic, or it is because of a Rhineck, just overnight sleep in abnormal posture and then getting up, the patient is having locked facet. Okay, so with the capsule or the ligament injury facet. Okay, so intertransverse ligament injuries, interspinous ligament injuries, supraspinous ligament injuries, everything has its own picture. So don't try to what is called as treat your sister, thinking all the girls are your sisters. Okay, that is one aspect. Okay, or all women like your girlfriends. Okay, both the things are dangerous. Okay, so do not what is called as homogenize like back ligaments, cervical ligaments. Okay, in cervical spine also. Apical ligament, alar ligaments, transverse ligament. Transverse ligament is death emergency. Okay, if there is a tear in the atlas, tectorial membrane. So what and what not. ligamentum nuchae. Okay, and in cervical spine, you also have what is called as upper cervical ligaments versus lower cervical ligament itself is totally different. Okay, so the injuries and the precautions what you have to take. Okay, so if you are treating them everything as like just like ligaments, you are doing the biggest blunder of your life. Next.
Right. Then we have a question from Dr. Farooq. He's asked how we manage the grade 2 ankle ligament tear.
You are not going to manage the grade 2 ankle ligament tear. You are going to manage the patient who is having the grade 2 ankle ligament tear. So that patient with grade 2 ankle ligament tear, whether the ankle movements, dorsiflexion, plantar flexion is paining in supine position itself, okay, or it is going to be paining even without the ankle movements at rest. So in supine is non-weight bearing. This is what I told. And open kinematic is without movement is static. At rest pain is there. Grade 2 ligament tear only. Rest pain is there. So that is static without movement. Next one is during only plantar flexion and inversion it is paining. Okay, lateral ligament. Or is it like dorsiflexion also it's paining.
Right.
So dorsiflexion it is paining means I'll assume that there is a syndesmosis injury also. The syndesmosis, tibiofemoral. Okay, this was actually covered in lateral ankle sprain masterclass. I think she can take that video so that I understand not only grade 2, totally lateral ankle ligament. Okay, how to actually go ahead with manual therapy and also rehab.
Right.
But what's important in the same grade 2 patient is a ligament tear patient another patient can tell that standing is paining, which is closed kinematic but static. Okay. Another that grade 2 ligament tear, lateral ankle sprain only, same ligament tear, same grade 2 only, but the patient will tell standing is not paining, but walking is paining. And that walking is paining with different footwear, different pain. Okay. So there is a different spectrum of patients who can have responses. Okay. And they come to you on day 1 with different symptoms. Okay. Some have people with supine lying, they have symptoms. Some have patients who have walking with pain. Okay, so you are not treating the ligament injury, you are treating the patient. Okay, and then the next one, another tells that I actually do jogging, and I after do jogging for this much kilometers, then I come back and I come in the stairs, and I have to climb the stairs up and down. When I'm climbing down, I am getting a what is called as a twist of the ankle, but there is no pain. Only that pain was there momentarily, but afterwards it went off. After that, I was able to walk normally. That is functional instability, which you are talking about a repetitive loading in closed kinematic chain. Okay, fatigue induced. So this is the category which is important rather than grade 1, grade 2, and grade 3, because grade 1 also can have all this picture. Grade 3 also can have all this picture. Okay, grade 2 also can have all this picture. So this picture is more important than this 1, 2, 3. Okay.
Yes.
Right.
Yeah. Then we have question from Dr. Sumit. He's asked, flexion deformity is common after knee ligament tear. So how to cure?
Who said that flexion deformity is common? Okay, I don't think so. Okay, so because the subject keeps the knee flexed, it will become flexion.
Yes.
Otherwise, ligament injuries will not cause any flexion deformities. Post-operatively, it will cause flexion deformities because most of the immobilization, patient is kept in a loose packed position of the knee, where 15-degree flexion. Because post-operatively there will be effusion. So for that effusion, the loose packed position is attained. Okay? So 15-degree flexion automatically will come. So that's why ACL reconstruction or it is total knee replacements, we always get a flexion deformity. Okay. But ligament injuries will not cause the flexion deformity. It is the post-operative. Okay. Ligament injuries will cause instability. They will not cause any deformity unless and until poorly managed, mismanaged by the physiotherapist. Okay. And of course, the muscle imbalances are being ignored. Okay. Hamstring tightness or posterior capsule tightness ignored. Then only it will go for the deformity. Deformity is a complication of improper rehab.
Right.
Deformity is not a consequence of a clinical feature. Okay. So remember that. It's a complication of improper rehab. So that is the thing. Or complication following a surgery. Okay.
Yes, sir.
Right.
Then Dr. Tashrif has asked how to manage ligament injury if it persists even after surgical intervention.
It can be after surgical intervention or it can be before surgical intervention. I'm not bothered about what was the thing. My thing is, in surgery, what are the major structural changes are done? That I should know from the surgeon. Okay.
Yes.
If there is a graft that is kept, means whether the graft is strong or weak, how long, how much functional activities it can take, and how the bone that is there next to the graft, whether it was strong or not. This I should know from the surgeon. Okay. Without the surgeon's clearance, I cannot do. But our rehab is not going to change, whether it is a what is called as first time injury or it is recurrent injury. Okay. Recurrent injury, it will affect the central sensitization. Okay. Other than that, there is nothing much which you have to do here locally. And remember that recurrent injuries are much easier to manage functionally than first injuries. Okay. So post-operative, again, if there is a ligament tear, that means graft failure. If the graft is torn, means the patient should go straight to the surgeon only. Okay. ACL reconstruction, and after that, again the ACL is torn. Okay. That graft which they have put patellar tendon and that is got ruptured again. Do not touch the patient. Directly send them to the surgeon again. Okay. Because the operated ligament itself has got torn. So the operated person only should take care. If you are trying to manage anything, surgeon can easily tell that because of your management only it has got worse. Okay. So do not touch that at all. Okay. It's a red flag. So if it is not the same ligament, if it is another ligament, no problem. If you have the surgeon in your confidence that you know the strength of the bone, you know the strength of the graft, definitely if after an ACL reconstruction, if a patient is getting MCL injury, okay, treat them like a normal person who will get an MCL injury. But the precaution what you will avoid as per the surgeon's advice should be avoided. If you feel like you can progress, but the surgeon is not aware of it, is not giving the clearance, means convince the surgeon. If you cannot convince the surgeon, don't do on the patient. Because it is post-operative. The whole recovery is taken care by the surgeon. Okay. So do not go against the surgeon's word. Do not try to create a confusion in patient. What to tell the patient, be clear, discuss with the surgeon first. Okay. And then be sure that what you're going to tell, what you're not going to tell. Okay. So be very clear about that. Okay. Today, if you blame the surgeon and you are taking the patient's side, okay, tomorrow the patient will blame you. Patient will tell that always it's psychology for the patient to see who's vulnerable among the two, whether the surgeon or the physical therapist. Okay. How much ever you are competent, how much ever you are famous, how much ever you are really doing your level best for the patient, when the worsening happens, if both of you are there, surgeon and therapist, both are there in front of the patient, and if the patient is asked, okay, whom do you feel is the reason for your lack of recovery? Okay. Never will the patient tell surgeon because they were unconscious. They were in the operation theater. They don't know what is done, what is not done. They only know an MRI, which is taken only before the surgery, not after the surgery. Understood? Post-operative, only X-ray will be taken. No, if the arthroscopy or the ultrasonography was done before the, or MRI for ACL tear was done before the surgery, you show me one patient, ACL reconstruction post-operative in whole of India, one patient, post-operative MRI was taken and shown that ACL is intact. One single patient you show me, post-operative MRI is there. It will not be taken by the surgeon at all. If you have shown post-operative MRI is taken, I will give you the tomorrow's course free of cost. Full free. Course is still free. Lifetime membership also. Open challenge. If any surgeon has that, after reconstruction graft, take an MRI again. This is the reality. So the patient will always believe. They are shown like one tissue specimen. This is the ACL which we removed. the specimen will see, okay, torn ligament removed now. That is the thing which we are creating, structural problem. It's been corrected structurally. And the patient is shown an artificial knee joint. See, and the poster is there, patellar tendon, how we are getting the reconstruction. Okay. Our video of the surgery may be shown, how we are doing this. So patient will feel, okay, patellar tendon is taken, it's very strong, and it is taken and it has been replaced. My ACL is, the torn ligament is removed and it has been replaced. This is what is created in their mind. We spend 1 hour, 1.5 hours with the subject, and we actually concentrate on all the functional recovery. But remember that patient will never support you when there is a choice for them between you and the physician. Okay? Very few patients will tell that they are supporting, but in front of the physician, they will openly tell, yeah, during exercise only it was paining.
Very true, sir.
Okay. So that is why I am telling, make sure that the decision making, your background, your influencing factor is the patient's priority, the goal. But you will not take the decision, all the responsibility if the patient is operated.
Yes.
If the patient is operated means surgeon always comes in the picture. Discussion with the surgeon is always important. Keep the surgeon in confidence is always important. Medico-legally also I am telling, even where Maharashtra State Council is there. Okay. If a patient is being sued by a patient, will the council come to protect? Okay. So we think that lack of counsel, lack of security like that. Will the council protect? Nothing. A patient's relatives are coming and hitting the physician. Whether MCA is doing anything? Nothing. Only IMA is doing the protest. Indian Medical Association, not the council. So what is important is the unity. That is the power. All of them will go for strike. If one nurse being ill-treated by any patient or relatives, all the nurses will go for strike because the nursing association, not the council.
Yes.
So what is important is that all the protest and the lobbying is done by the association for a pay scale, for a independent autonomic practice, okay, autonomy in clinical practice, decision making, responsibility, everything. And insurance policy. You want to take a medical indemnity insurance. As a physical therapist, I can do treatments. And if the patient is suing me legally, okay, I cannot pay the money. The insurance company will pay the money. That system is not there in India. If the medical indemnity insurance is there, it goes with medical. Are you a registered medical practitioner? You can't be a physical therapist and be a registered medical practitioner because registered is in the council. Where even if you have a registered physiotherapy practitioner, where you are prefixing doctor in Maharashtra State Council, okay, you are a registered practitioner, but you are a registered physical therapy practitioner. You are not a medical practitioner. Under the insurance company's description and the criteria and things, you never come in the picture at all. Registered medical practitioner means only those who are registered under Ayush or registered directly as even veterinary practitioner. Okay, they are also coming under medical practitioner. And then another one comes to this medical and dental. Okay, so make sure that be aware of the legal aspects. Okay, and never what is called as when it comes to choices. Okay. The legally whoever is responsible should be given more respect. That is the physician. That is the surgeon. Okay. They are taking care of the full legal responsibility for the recovery. So make sure that you also go by discussion and approval by them.
Right,
okay?
sir.
As per
Yes.
their directions. Yes. There's
Yes.
nothing wrong in taking their directions, but it is wrong if you are not able to convince them. Okay. You are not able to explain, and you are not able to explain in a proper way to make sure that you are not hurting their ego. You are not trying to show off your extra knowledge. You just want to do best for your patients. Okay? If you convey this message across, and if you fail to convey this message across, you are not an expert at all. Okay?
Yes, sir.
Yes.
Yeah, then we have Dr. Farooq has asked, what are the useful techniques to manage shortly after ACL ligament reconstruction?
So already covered functional level. There is no
What are the-
techniques in this.
Yeah. Dr. Monisha has asked, what are the risks of ACL surgery?
Risks of any surgery is infection.
Hmm.
Risks of any surgery is a failure of the graft. Okay, after the repair also again failure can come.
Yes.
Risk of any surgery is the deconditioning after the surgery. Okay, initial phase, like a flexion deformity, a scar adhesions. Okay, so these kind of complications that can happen. Even complications of anesthesia, if it is general anesthesia, if it is given. Otherwise, spinal epidural risk can be with the epidural anesthesia. Spinal back pain can come or headaches can come. Okay, because the anesthesia was injected into the CSF. Okay, so these kind of things are to do with the procedures or with the care following the surgery. Okay.
Right.
Otherwise, the actual risk which I was telling is the surgeon is not performing the surgery and the postgraduate surgeon student is doing the surgery also is a risk only. Okay.
Yeah.
So anything can happen. Sometimes in general government medical colleges, postgraduates only operate. Okay. But those postgraduates are better than the surgeons in private hospitals. Okay. Because surgeons in private hospitals, they are doing the surgery because hospital wants them to do the surgery. But the postgraduate students in government hospitals, they are doing surgery because daily they are seeing patients in extreme ends of the spectrum and their skill is much better in managing the complications also. Okay. So there are a lot of differences, the types of surgeon and their experience and everything recovery. Of course, the last part, which is in your hand, is the physical therapist who is handling the patient post-operatively. Is a major question mark, because if it's over-motivated physical therapist, but under-competent, no knowledge, only motivation is there. I am a movement scientist. What do you know about movements? Okay. And you are a certified practitioner. Come to me. I will ask 2 questions. If you answer both the questions, I'll give tomorrow's course free. Okay. You cannot upgrade your skill. I vouch upon everybody, whoever is doing the courses already in AOMPT, the core committee also. Even after doing all these courses also, still they can give a picture. Okay. They can give a clue, but nobody can provide an answer. Okay. Because the answer lies in the patient. Okay. Answer not lies for the topic. Okay. But when it comes to understanding of the patient, you should understand the aspects in multidimensional. Whether it is anatomy means the differential. What are the structures related to that? Nearby, which are all structures are there? If it is biomechanical means open kinematic versus closed kinematic, static versus dynamic. Okay. What are the stability versus mobility? What are the issues? Okay. So it comes as a, what is called as a model of decision making. Okay. And functional goal, which is problem oriented. What is important for the patient? So that should be the emphasis. Like,
yes, perfect. Yeah. Then Dr. Manisha has asked how to diagnose whether there is ligament injury, tendon injury, or other injuries.
already explained.
Yes. Then Dr. Tanu has asked, can medial meniscus be repaired by itself, or somebody has to go for surgery in geriatric cases?
A geriatric already I told, and also
Yes.
I told that any ligament you can just
Yeah.
go for spontaneous or conservative treatment. With
Yes.
the activity demand not there, you don't have to go for surgery. So
Yes. Then Dr. Shafiq has asked how much time it will take to cure partial tear of ACL, and can we give knee braces for ligament injury and for how long?
as I was telling for assistive devices, the bracing and taping, I told that the faster we discontinue, it is better. Okay. You are using these devices just to improve the functional training. Once the functional performance improves, you should discontinue. Okay. There's no fixed time there. Okay. If you are talking about phase-wise rehab in the ACL, they tell about the translation. Okay. This many millimeters, it is less than that other side. Okay. You have a unilateral hop, unilateral squat. The performance is 80% compared to the opposite side. Okay. Then you can progress to the next stage. Okay. So this kind of criteria-based progression. I don't go by that mathematics. Okay. What you have to see is, as I was already telling about the frequency, the performance in the functional training, everything. Okay, I highlighted earlier. So that will be the criteria for progression in rehab.
Yes. Yeah. So then we have a question from Dr. Pal. A 18-year-old football player with complete ACL tear had a surgery 3 months back. Please guide exercises.
First, we have to know what is the surgery. Okay. So you
Yeah.
can't guide an exercise without knowing the condition. Okay. So the surgery can be repair, surgery can be reconstruction. Reconstruction can be with the grafts. The grafts can be patellar tendon or hamstring tendon. If it is to do with natural grafts, which is from the tendon grafts. If it is artificial grafts are also there. Okay. So there are chemical materials, fibrous ligaments artificially that also can be used for reconstruction. So what was used? How much the ligament is strong? So related to surgery. Next is the patient. What is their functional goals? Okay. So what are the movements which are difficult for them? Which are the activities which they have to reach? And what is the time frame that we have to reach that? So based upon that only my training will go and my rehab will be structured.
Right,
Yes.
sir. Yeah. Then we have question from Gabby. What about the bone fractures in sports? It can also lead to ligament injuries, be it direct or indirect.
What about means? It is about fractures. That's all.
Yeah. Yeah.
What is there about in that? You know that when there is bony injuries means more immobilization, more surgery, okay,
Yes.
indication comes automatically. Only a ligament injury versus a fracture with ligament injury. Your goal goes to the fracture first. Okay, your priority is not ligament there. Okay,
Right.
and if it is even it's an avulsion fractures, you have to go for the fracture fragment that is being fixed. Okay?
Right. Yeah.
Yes.
Then Dr. Shreya asked, which are the activities where ACL is commonly injured, which you explained.
Already explained. Yes.
Yeah. Then Dr. Harish has asked, functional difference between ligament and tendon.
Already explained.
Yeah. Dr. Manjula has asked, why it is instructed to meniscus injury patients to avoid cross-sitting?
Cross-sitting because it stretches the meniscus. Okay, but it's not necessarily in everybody. Okay. Medial meniscus, whether the injury is because of compression or injury is because of stretch. Okay. If you are doing cross-leg sitting in figure of 4 or in the Padmasana, okay, and the patient gets the stretch of the medial meniscus. Okay. So that is the reason why it could be told that, but the indication should be stretch-related dysfunction. Then only that should be avoided. Okay. If a person is having close kinematic chain activities like on field and then twisting, running activity, football, and after that he got the medial meniscus injury, don't tell him not to sit cross-leg sitting. Okay, because cross-leg sitting is open kinematic. Okay. So, and if there is no, the meniscus is attached to the femur, meniscus is attached to tibia, meniscofemoral, meniscotibial ligaments. Okay. Meniscus is also attached to medial meniscus to the synovial membrane and the capsule, medial capsule. So because of that attachments together, it might contraindicate if the associated injuries are there. Okay. Otherwise, meniscus will not cause pain only, because meniscus is not innervated. It is not at all supplied by blood also. Okay, it's avascular, aneural. Meniscus will never cause pain. Meniscus only will create clicks. Meniscus causes pain because of attached structures which are getting damaged. So it's important to know what are the attached structures. Whether those structures are painful in compression, then close kinematic is important. Whether those structures are painful in stretch, that means the stretching is to be contraindicated. Where the end range stretch comes in the cross-leg sitting. So for that patients alone, it has to be contraindicated, not for everyone.
Right, sir. Then Dr. Mohammed has asked, which physio intervention is more helpful for pain reduction and ligament injury other than electrotherapeutic modalities?
We have already discussed all this.
Yes.
But what is important is don't be political. Okay, which one is best? If you ask one question, well, who is the hero of today's movie, the 2 hours movie of interaction means functional rehab is the hero.
Right.
Okay? So that means that functional rehab you start in whatever way, whether it is the opposite side leg also you train when this leg cannot move, or when it can move, at least in supine position itself give the functional training, or when it can be standing, whether there also functional training, whether it is walking, whether it is overuse. Everywhere incorporate the functional rehab. That will be the best for functional recovery.
Right.
It will match. Okay.
Yes. So again, same type of question Dr. Pal has asked. Elder patient, 65-year-old farmer, MCL injury. So please guide exercise program.
In this elderly patient, what is the major concern? Balance. Okay, because they should not fall. Okay,
Right.
so your balance training interventions will come gain more picture. You will not give quadriceps exercises for that patient. Okay, or VMO strengthening and all. Okay, and then next one in the washroom. Okay, squatting, sit to stand, whether it is because of Western or Indian toilet, whichever. Preferably, you will modify that activity and make sure that they don't do a full squat. Okay?
Yeah.
And next one, if they are continuing with full squat, I want to continue with the full squat. If the patient tells that, okay, no
Yes.
problem. Only thing is pain adaptation. Okay, how well you can encourage the patient to get over with the pain and get with the descending inhibition. Most of the elderly have the descending inhibition good when you talk about spirituality, when you talk about religion, when you talk about music therapy, when you talk about group therapy. So they forget their pain and they do the functional activity and they become normal. Okay, meditations. So a lot of things comes. Okay, so in elderly, you have to know what are the aspects which is actually helping the descending inhibition. With that descending inhibition, even with the torn ligament, they can do full squat. Because nobody is going to bother if they have a genu valgum. Patient has to squat. This is what is their psychology, their mind. I should squat. Squatting is good for health. There's nothing bad with squatting. Okay. So you can't give a brace and then ask them to squat. Okay. You cannot put tape every day and then ask them to squat. Only thing is descending inhibition, forget it and then squat. So that stage will go when it comes to elderly. Balance training to prevent further falls. So I might give wobble board or the Swiss ball or all these lower extremity balance activities to ensure that eyes closed, eyes open for proprioception, all these things. To ensure that in dark environments also they should not fall. So that will be the major goal there.
Right. Yes. Then we have question from Dr. Monisha. It's repeated. Any special diagnosis for ACL ligament, ACL and PCL injuries? Yeah.
Special diagnosis. Okay.
Then we have
one special diagnosis is triad of O'Donoghue. Okay, because this kind of name means it's special. Okay, triad of O'Donoghue, which is actually the what is called as injury of MCL, medial meniscus together with the ACL. Okay. And another special diagnosis is what even Darshana has taken her first webinar for AOMPT, female athletic triad. Okay. So this kind of athletic triad can coexist with any ligament injury in a female athlete. Okay.
Yes.
So these are all things are special diagnosis. What you are going to do with that special diagnosis? Nothing. Okay. Yes, next.
Yeah. Then Dr. Manjula has asked, there's a patient who's getting physiotherapy since 1 year for meniscus injury to avoid surgery, but she didn't recover. At last, she underwent surgery for meniscus injury, but there's no
Still
question.
she didn't recover. Obviously, recovery depends upon functional training. If functional training not done, whether it is non-operative or post-operative, patient will never recover.
Yes.
If you are giving quadriceps exercises, you are giving ultrasound to the meniscus, giving scar mobilization, okay, without training stair climbing, without training squatting, without training walking, then how are you expect the patient to recover? Okay.
Right.
So always it's important to think functional.
Then Dr. Vijaya Ramakrishna has asked how to diagnose ligament injury. This you have explained.
Same question he asked before.
Yes. Then Dr. Tayaba, they've asked, so some school-going children have acromaclavicular joint pain due to heavy bags, but they didn't look it seriously, and they took painkillers for temporary pain relief, but now their pain becomes worse. Kindly tell me what mechanism happened in the AC joint due to heavy bags that leads to joint dysfunction, and how should I help them as physiotherapist?
See that heavy bags, it is direct impact on the AC joint. As I was trying to tell, a differentiation here, coracoclavicular ligament, AC joint capsule. Okay.
Yes.
So it must be the capsule only of the AC joint, which has got strained because of a heavy back. Okay. So either way, your plan will go to what is called as two options. Painkillers was a very bad intention, whatever they had, and I don't know why they took painkillers for children. Okay. Giving painkillers for children is like killing their childhood. Okay. And making them old in the young age itself. Okay. So what we should have been is aerobic fitness. If they are playing in good games and everything, they would have got descending inhibition to aerobic fitness. Okay. They need not have this. And another thing is, if the subject is having an instability of AC joint, on the unstable AC joint, if you are putting the bag again and again, then it will create a further capsular strain.
Yes.
So in that case, change the side intermittently, or see that the weight of the bag or modify the bag. If it's a backpack, it is good, not the side. Okay. Unilaterally giving weight bearing and then walking. Okay. Or why that bag is heavy. Okay. School. Okay. That you can discuss whether too many books they are carrying, too many notebooks they are carrying, what it is. Okay. If it is beyond that anthropometry, to touch a small child and then too much of weight, it is illegal. Okay. And if the child is carrying the boy, but he has girlfriends in the school and he is carrying other girls' bag and all, means that we cannot help. Okay, that is own choice. Okay, so girls will never carry other people bag. Okay, so the next thing comes to brother also carrying for sister may happen. Okay, too much, where he is having generalized hypermobility and still wants to show that I am a boy. So he wants to carry a heavy bag and he wants to go. This is wish. Okay, the psychosocial factors will come. So don't think that you have to rehabilitate the subject every time. Okay, you have to address the risk factors. Okay, risk factor control is also part of the rehab in order to prevent the recurrence. And optimization of loading, that is also important if it is too much beyond the anthropometry or age.
Yeah.
Next comes to stabilizing the acromioclavicular joint, then improving the rotator cuff or the upper trapezius strength.
Yes.
Eccentric strength, upper trapezius, so that they can hold the bag and then go longer distances. Okay.
Right.
Right.
Yes. Then
If
we
you
have
see that alignment issues, shoulder dropped, scapula, okay,
Hmm.
scapular dyskinesis are there.
Right.
So with that acromioclavicular instability together, it's common. So in that case, correcting the scapular imbalance, serratus anterior, or it is the middle trapezius.
Yes.
So these kind of or pectoralis minor tightness, third, okay, Kibler type 3. So various things you have to come in mind. That is why in the course material, the course study material, I have distributed the scapular dyskinesia and shoulder instability. Okay,
Right.
that so that we get the picture that tomorrow we are starting with shoulder instability. So
Right.
scapular dyskinesia plays a larger part in instability of the shoulder. Okay, all the three types of Kibler.
Yes.
Right.
So then Dr. Shagira asked, so will dry needling help in ligament healing and on field sports injury?
The commercially distributed or the what is called as instructed from Mumbai, especially. Okay, there's a resource person. With due respects to him, he's a great clinician who has explored the dry needling into ligament, bursa, capsule, nerve. I think in blood vessels also he'll do dry needling. I don't know. Okay, arterial diseases can be cured by dry needling for artery. Venous thrombosis give the dry needling for vein. We don't know. Okay, he may be doing periosteum needling. He is doing periosteal pricking. Okay, he's doing a lot of things. Dry needling he is doing everywhere. Okay, so it's his clinical experience. So I am not commenting on what improvement he got in his patients are fake. Okay, but what I am trying to tell is think logically. What is the indication for the dry needling? Just because you are a certified dry needling practitioner, don't use the dry needling. Okay, why are you doing an invasive treatment? And whenever you are doing an invasive treatment, I will always question what are the risks and the benefits. Okay, so first thing and foremost, Are you legally allowed to practice dry needling in India? And the next thing, what are the legal issues? Medical indemnity insurance. Does it cover a physical therapist giving dry needling? And if there's a side effect, the patient goes for treatment or surgery further afterwards, whether the financial expenses are covered by the insurance company, whether that insurance company lists that it's part of the physiotherapy treatments, dry needling.
Yes.
Next question, needle disposal. Your corporation registering your clinic as a what is called as a center registration, okay, where the corporation people will pick up the dry needling from you under biomedical waste disposal system, like they do in the hospitals. Or you are putting in a plastic bottle and closing it and putting in a nearby hospital. That means that you are not legally allowed to practice dry needling. Get it, come to the fact. Okay? Whether Ayush practitioners, they have put, Ayush has given a ministry order, central ministry order. Nobody can practice dry needling unless they complete acupuncture course. Indian Society of Medical Acupuncture and Ayush together. You cannot practice dry needling without having a degree in acupuncture. You can do an MD acupuncture from Sri Lanka in 1 week, which is just online money only. Just you will get the degree, MD acupuncture, 1 week itself. But still, without that, you cannot do dry needling. This is the legal aspects again. Beyond all this, if resource persons on dry needling are teaching dry needling and therapists are getting certified as dry needling practitioners, so they have to use dry needling means, God bless you. I will come as the patient to you and I will take the dry needling by you and I will sue you and I'll get 15 lakhs out of you. Nobody can stop it. All your life saving gone. So in spite of this, you feel that hurting the tissue only will heal the tissue. Because needle, skin it is not hurting, correct? But how the trigger point again circulation is coming? By trauma, micro trauma. Why needle manipulation is there? There is micro trauma there.
Yes.
We are doing from outside, we are doing the deep transduction massage. That is by pressure. There is no tissue hurting. In dry needling, you are doing that. In trigger point also, in every tissue dry needling, you are doing that trauma, micro trauma there. And you are expecting that to heal. Yeah. What is the indication that much it has become avascular? If that much it is avascular, means whether the needle will create any kind of vascularity. And can't the needle damage the capillaries? If it damages the capillaries, can't it cause a blood leak there within the ligament, within the trigger point? Can't that blood leak again become a scar in the trigger point?
Yes.
What is that which you are expecting? Again, after dry needling, you have to do optimal loading. Again, after dry needling, you have to do the deep transduction massage. You cannot tell that the recovery is only because of dry needling.
Right.
So remember, with all these benefits versus the risk and the legal everything, be it soft tissue injections, we can do Syriac soft tissue injections are there. That also ligament injections can be given. Ligament partial tear is there, inflammation is there. So you can directly inject a steroid to the ligament. Are you legally allowed to provide injections as a physical therapist in India? Even if you are certified by the Syriac European Training Group of Orthopedic Medicine, EDGOG, you cannot still do the injections. And if you are doing injection, I will come and take the injection. And next day, I will sue you for 25 lakhs. Beware of it. Okay? So be seeing the legalities. Do not do anything illegal just because it looks fancy.
Absolutely.
Your fundamental techniques are fundamental. Don't think need for an additional technique unless you feel your brain is incapable. Okay?
Right.
Right. Next.
Yes, sir. Then we have a last question.
Yes.
By Dr. Pal.
I disabled the questions a long back. Otherwise, it would have kept on coming.
Okay. So it is incomplete. Complete ACL injury, sports person, wrist sprain, lunate, and scapulolunate ligament injuries. That's it. Yeah.
Okay, only topics are there. All these are there, the topics in the ligament injury course. Okay. as we have discussed, wrist injury, ACL injury, okay, every injury.
Yes.
And remember that these master classes are again 2 hours it is scheduled, but usually AOMPT's master classes goes for 3 minimum. Today's also you would have seen that 4 to 6, but we are going till 7. So we never see the time. Okay, what we see is the content and knowledge, and the participants which are core committee were always attending live on the screen. Okay,
Yes.
so that is how we actually what is called as have a productive interaction, okay, constructive interaction. Ritu ma'am is still not unmuted. I think
Yes, sir.
Gabriel is from Lebanon. Okay, curiously looking Gabby physio.
Okay.
What Gabby? What do you want to say?
I just want to say thank you for this valuable information, Doctor. And it was a really great pleasure because I honestly asked about the mobilization techniques because I mainly use them. I use mostly Mulligan's
Mobilization and
technique.
movements.
Yes, the Mulligan's
That is
technique.
very useful. But what I
Yes.
advise is during
Yes.
the exercise training, give
Yes.
the MWM. Okay.
Yes, for sure.
So that
And
you will find immediate recovery. Exercises become pain-free.
yes, very
So that the
immediate
subject's
recovery.
recovery will be better.
Because I honestly use them also on the playground because I work with football teams also mainly. So I use such techniques for immediate recovery because, and I also afterwards I use kinesiotaping for recovery, and in case I needed I use also something we call the adhesive bandage just to maintain the kinesiotaping
Correct.
in place.
After the taping, you can put the adhesive band-aid above that.
Yes,
On the
that's what I
field,
do.
yes.
In fact, that's what I do, and I just put one layer over the kinesiotaping tape just to hold, and it's been
Otherwise,
like
the
8 years.
sweat or the what is called as hair, sometimes the kinesio tape might get little bit looser. So
Yes,
put the
yes,
bandage so that it
yes.
stays. Correct.
I put more than one layer mostly because we mainly the football players are somehow hairy, especially when they're still growing up. Like I'm working with teams aged 12, 13 or 17, 18. So
And mostly
but
on-field rehab, you
yeah,
need to what is called as ensure that these players, because you can't determine which direction they will get the force. Okay.
yes,
You put the
that's
tape
very
only for one ligament. It's not solved. So you might
yeah.
put the compressive bandage so that the whole knee is what is called as offloaded, and
Mhm.
the hip and ankle will take care till the game gets
Yes.
finished. So after
Yes.
the game, you can go ahead with the more focused.
Yes, for sure. Yes, for sure. But mainly after the game, they feel like after I go for my treatment and everything, they feel better and they even can perform better on the playground, like during the matches. Once I use the mobilization with movement, the ligament injuries are reduced a lot. So it's very important. That's why I asked about the usage for ligament injuries.
Okay. And gone are those days when we think ligament injury, so hypermobility, so no need to give mobilization. Okay.
Yes.
So now it
Yes.
is the functional mobilization. So that is mobilization with movement. And of
Yes.
course, exercises with strengthening and re-educating the muscles. Whether it is walking mode also during that
Proprioceptive exercise. Yes.
boom also give
Proprioceptive training.
MWM. Swiss ball you give the MWM. Or even
Yes.
a task, bowling task, or it is a patient is doing on a track, okay, and then
Yeah.
doing it. There also
Yeah.
administer
also-
the MWM and give the tape, the mulligan
Yes.
tape, okay, and
Yes.
then ask the patient to do.
And
Definitely.
I also use proprioceptive training for football players. Like I use the Freeman plateau, and I use the cones to for them to jump laterally or forward jumps or backward jumps, so that I ensure that the stability in the ankles and in the knees also to help them, because mainly football players use their knees and their ankles. So pre-game I use somehow the proprioceptive training with cones, with sticks, like lateral movement or forward or backward movement with
Yeah,
ball
initially
or without ball.
unidirectional, then multidirectional, then rotational.
Yes.
Okay.
Yes.
So every
Yes.
challenge we can give.
Yes, I use all of these
Eyes open, eyes closed. and then stable surface, unstable surface. Okay.
Yes,
And
yes,
then next comes to even the reaction time. Okay.
yes,
So
yes,
how we can train all this. Yes.
yes, for sure. Yes, for sure. Thank you, doctor. It was a very nice intervention from you, and we're looking forward for more.
Yeah. You should make sure that in Lebanon, you hold the course of AOMPT. Okay.
Yeah.
So you speak about your side of the MWM and the neuromuscular training drills. I tell about the rest of the manual therapy and the concepts what we have in AOMPT. Okay.
If I may ask, doctor,
If you are joining AOMPT, you'll be the first member from Lebanon.
Thank you. It will be a great pleasure for me. And I would like to ask if you guys are up for any Mulligan seminars or certifications, or Mulligan or Mackenzie certifications. If there is anything online,
Yeah, there are a lot of courses available, but the problem is certified Mulligan practitioner, that will not be provided by the AOMPT. Okay. Because that is provided by the Mulligan Concept Teachers Association. Okay. And the certified Mackenzie practitioner or the MDT practitioners will not be provided by the AOMPT, because that is provided by the Mackenzie Institute International.
If I may ask you,
but
doctor,
all the techniques are covered as part of the manual therapy, and we have that as part of the disorders. Every conditions we use all these techniques. Okay.
Yes.
And so you are actually certified to be a clinical certification. So it is more of.
If I may ask you, doctor, if you have any links or any contacts so that I can ask them about this, can you kindly provide them to me via WhatsApp? Thank you, because I need such contacts, because you know better, because you're in the atmosphere.
But what I feel it is better is not getting certified in a particular technique. Okay? That is better. Because technique wise, if you get certified, it will not make you better. What will make you better is a sports certification, a sports injury certification, okay, or a conditioning certification, okay, or the what is called as the injury or the diseases, that conditions related to that certifications. Okay.
Yes.
Because if you're going for technique centered one, the problem is they have a different protocol of evaluation, different protocol of treatment. You will not be able to integrate it parallelly. Okay. And you are also bound to document all the cases and give it in their formats. Okay. If you are a certified practitioner, you have that expiry date. So by that time, you should complete and give all the case documents. Okay. In their format, you should submit the findings of every case. Okay. The treatments. And when you are a certified Mulligan practitioner, you tend to see whether this patient A is suitable or patient B is suitable for my Mulligan's technique. Okay? So we are selecting the patient for the technique. But if it is patient-centered, the other way around, we can do multiple techniques, treatments, and we can give the improvement on the patient. As you are doing in your practice, you are combining therapies, you are combining the concept, you are developing your own combination.
My own combination.
That is the one which is best. And you know the same patient, right leg versus left leg, it's different.
Yes,
okay?
And that is why I want to learn all the techniques.
If you are giving a talar glide and lateral ankle sprains, one you might give posteromedial, the other you might give even only posterior glide. Okay, it might have helped. So directions of MWM itself has to be customized. Okay, so some might require with the myofascial techniques, some may not require the myofascial techniques. Okay,
that is why I would like to learn all the techniques, doctor.
So try to see that you learn the comprehensive picture. Okay.
Yes.
Don't get individual certifications. We have certifications in AOMPT like spinal manual therapy. Okay. So
yes, that's awesome.
So fully for the spine. And we had a cervical spine specialist course. So you would have seen the flyers there. So where we get all the disorders of the cervical spine. So lumbar spine specialist course. That is all the disorders of the lumbar spine and low back pain. Everything with manual therapy.
Perfect.
So those kind of ones will be more clinical. And the course material which is available online as videos, it includes all manual therapy techniques. Okay.
Okay.
And the practical
kindly-
demonstration also includes the MWM. It includes Maitland. It
Perfect.
includes Butlers. It includes myofascial techniques. Okay. Everything is there for that disorder.
Perfect.
So,
Thank you.
and
I would
you get a
thank you a
comprehensive
lot.
picture. PDF materials also
Yes.
gives you the research evidence and
Mhm.
also gives the theoretical background. Okay.
Perfect.
So,
Perfect. Thank
for
you a
those
lot, doctor.
concepts. So try to see
It was-
that get the
Yeah.
payment. It's possible from Lebanon, so there's not a big problem. You can use the PayPal and you can do the
no,
fee payments.
we don't. We in
Okay,
fact
so
we don't
don't be
PayPal
just
here.
consult some of your friends. They will help you with the Western Union money transfer or with the PayPal.
Yes, but
Okay.
but
So
here we
definitely
have PayPal in fact,
across
yet.
the boundaries and the globe,
Well,
we can
we
connect.
can try. I can try sending via Western Union in case
Yeah.
Western Union or OMT because
So
we don't
coordinate
have
a team
PayPal
of
yet.
physios at your place, 10 to 15 physios together. And then when you join
I
the
will
courses, you can
I will
watch the
try.
videos and practice on each other. Okay.
Yes, for
And
sure.
I can watch that videos and I can give my inputs. Okay.
Okay.
So that
okay.
way you
And
can
in case,
get
in case
confident
I
in
was
your skill.
yes, and in case I was practicing alone, I will try to provide you with the videos on Zoom or on WhatsApp or in any way I can do. But kindly, if any courses about manual therapy, because honestly, it is my interest, and
It's
I'm
not about,
planning
you
on
need not
having a
ask
master's
any courses.
degree.
There is every courses on manual therapy is available. Okay.
Perfect.
So there is no
Perfect.
single region,
Any
no
course you
disorder
can
that is not
provide.
covered by AOMPT. Okay. So we
Okay,
have
thank you.
all techniques for articular, all techniques myofascial, all neural,
Thank you.
advanced techniques, combining all the three, functional,
Okay, very nice.
everything is
Thank you.
available. Okay?
Thank you.
Nothing that is not available.
It's a very great pleasure. It's a very great pleasure, doctor. So
Yes.
thank you a lot for this meeting again. And I will be leaving now because we
Okay,
mainly
sure,
are done,
please.
aren't we?
We are also leaving now. Okay. So that is how we have come to the
Yes, I am.
conclusion.
Yes.
Great to
Thank
listen
you.
from you across the countries. And
Yes, thank
keep up your good work and keep
Thank you.
inspiring people.
Sure.
Stay blessed.
Thank you.
Make sure that
Bless you.
your betterment creates a better world around you. Okay?
Thank you. Thank you,
So,
doctor. Same to you. Have a
good luck
blessed
to you.
day. Thank you.
Happy.
Have a blessed evening. Have a good night.
Yes.
Bye.
Okay.
Bye. Thank you. Bye.
Yes. So yes, Darshana, Dr. Ritu ma'am will give the closing words.
Yes, sir.
Yes, sir. Yes, sir. As always, that we all know that how we are learning from AOMPT is a very different. Every course is coming like this. Dr. Physio Gibbs were saying that about that only specific for one technique. But if he will come and enter in the AOMPT, he can understand that how much variety of courses we have for everything. You just spell the word and the courses available here, either the tipping and everything that which you have already explained to him. So according to the today's session, if we are talking about the ligament injury, yes, it was very important topic because when we treat the patient, either the dysfunction any the knee or the back or the shoulder, so we confuse the ligament injury to their
Wait, Dr. Darshana, are you able to hear a voice properly?
instability comes. So according to the organization is
No, I'm not able to hear. It's like crackling.
It's becoming like a computer voice.
sir.
Yeah, it's not clear.
Yeah. Maybe because of the internet only.
Yes.
Madam is having issues there.
Just out.
Now she is becoming mosquito skeletal. Okay.
Yeah.
So she'll
Now
again
it's
come
clear,
back. Sometimes, yeah, this internet in the
clear, sir?
evenings is very unpredictable.
Yeah.
Yes, sir.
I am also
Sir, it's
surprisingly I am
audible?
on the other SIM. And,
Audible, ma'am?
No, we can't see you, but
no problem. If she is coming on the screen, I think it becomes volume is cracking audio. Okay. Right.
Maybe I just go towards other side of my home. There will be
proper internet. Now it's clear, ma'am?
Yeah,
Voice
bit.
is clear.
Okay.
We are not able to
it's-
see you. Where are you? You have to
Now
unmute
it's-
the video.
Yes, sir.
Hmm.
So now you are not
Now
on the
it's
screen.
audible,
Screen
sir?
is not visible. Yeah, now visible.
Okay. Yes, sir. Okay, sir. Fine.
Yes.
Yeah.
Okay. I can say
Yes, sir.
the frames are moving like the images. It is like a set of pictures. Like that it is moving. Okay.
Yeah.
It's not like an actual movement. It is like multiple angle isometric.
Right, sir.
Okay. It's not a dynamic concentric or eccentric strengthening. This isometric, 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 isometric. So like that. Okay. Same like that the pictures are. Right.
Yes,
So we
sir.
are ready to close the session. Ritu ma'am?
Yes.
Yes, sir.
Okay.
Yes, sir. Thank you so much for
Hope you enjoyed the
excellent-
session and all. You also got the
Yes.
inputs on how these master classes are going to be. Okay.
Definitely.
Yes, sir.
And you have been seeing the functional perspective throughout. Okay. But we have been seeing
sir.
it for dysfunctions and stiffness, hypermobility. But for
Yes.
hypermobility, now we are going to see. And it is going to be an advance from the functional neuromuscular stability training and the pressure biofeedback specialist course. Together it will come everywhere. And then going into what is called as the ligament specific.
Yeah.
So shoulder means
Right.
it will involve complex, AC joint, sternoclavicular, and glenohumeral. But I'll concentrate on the major ones: anterior, posterior, and the multidirectional, and then go to the AC joint. Okay. See that the concepts of management are clear for major ones. Then the minor ligaments we can already get into the what is called as which are the functional ones if you know, like push-ups or what it is in this upper limb activities like rowing. Okay. So then definitely these two are open. One is the closed one. Okay. So that is the one which we are going to do, whether it is sitting push-ups or wall push-ups or prone push-ups or it is a supine push-ups. Okay. So we can modify. Okay. So
Right.
the functional activities that of the upper limb in closed kinematic and open kinematic. So these are the things: unilateral versus bilateral, role of thorax. Because what we actually have in instability on one joint, because the instability is there in that joint, other joints will become stiff. Okay.
Right.
So that associated picture will be mentioned. I will not show thoracic spine techniques or the regional interdependence, other regions. Okay. So, but it will be there as part of the session. It's only 2 hours, so there is no separate pathomechanics session. But before starting the practical demonstration, I would give a outline 30 minutes like that. Then our Gautam model will come. Then we'll have the demo. Right?
Okay.
That is
Yes,
how I
right,
plan.
Yes,
Right?
sir. Right.
Yes.
Let's hope that Ritu ma'am will attend the session from inside the house tomorrow.
No, sir,
Otherwise, it will be-
I was completely inside the house, but just a moment, there's some signal problem. So otherwise, no problem at all. Yes, sir.
Okay.
Yes, sir. Thank
So,
you.
see you. Bye-bye. And
Bye.
appreciate your contribution. Also, Dr. Paramita came in between. Dr. Sharoni was there in the beginning. Exam going candidate.
Yeah.
So, right.
Right, sir.
Okay. See
Right,
you.
sir.
Good luck to you both.
Thank you, sir. Thank you.
Enjoy
ma'am.
the course
Yes.
from tomorrow.
Yes.
And
Yes,
of
sir.
course, keep inspiring.
Yes, sir. Thank you.
Thank you, sir. Thank you, ma'am. Bye, ma'am. Hare Krishna.
See, not only our Gabby, you keep even Brian Mulligan to listen or watch the demonstrations, or you keep even any expert in any technique, whatever they are instructing. Okay, let them come on the screen. Let them tell that what I am thinking, what I am treating is wrong. Okay, so the thing is the decision making, what is arrived. It's not. I am not responsible. I don't know why how I am doing this. So, but what the point is all fundamentally correct. Okay, so
Yes.
that is right from the pathomechanics to mechanics to anatomy to that extent functional. Okay, so that way. So that is how we are getting that global acceptance. Okay? People who watch these videos, I am also not afraid to put the videos anywhere. Okay, because I know that whoever watches, they know that they cannot tell it is wrong.
Yeah.
And if anybody tells wrong, let them come for a debate. And if they are proven correct, I'll give all courses of AOMPT free of cost with certification. But if they are wrong, they should take all the courses paid in American dollars or whichever value. Okay, so that is the dare, okay, the challenge. Okay, what I can provide. So make sure that these inputs will help you in understanding the body better, okay, the system better in terms of how they all work together. Because working together only is success. Working together only is improvement. Okay, so individual work is not anything. Okay.
Right, sir.
Right. So see you. Good luck. Bye bye.
Yes, sir. Bye, sir.
Bye.
Good night. Yes, sir.
The recording.